doctors in various medical legal issues. I welcome Dr. Nagpal for his lecture. His topic for today is mob violence, how to tackle.
Thank you, Dr. Sirohi. Thank you so very much for inviting me. Am I audible?
Yes, sir, you are audible.
Okay, so the topic given to me today is mob violence and how to tackle. The first thing I would like to do here is to describe what are the various types of violence which happen in hospitals or in workplaces, in medical workplaces. There are basically four types which are described. The first one, where the perpetrator has no association with the hospital. Second is where the perpetrator is a customer or a patient of the workplace. Third is where the perpetrator is current or former employee of the workplace. And fourth is where the perpetrator has personal relationship with employees, like a husband of a nurse comes and does assault inside the hospital. So these are the basic four types which have been described in Western literature of violence in hospitals. Problem in India is we have a fifth type which doesn't fit into any of these subtypes, in the sense that we have something which we call mob violence. Mob violence is not reported in Western literature, and this is something we deal with on a nearly daily basis in India. Since violence is a universal phenomenon, we have reports from UK, USA, China, Israel, Pakistan, Turkey, Bangladesh. Mob violence against doctors is unique to India and a few Southeast Asian countries. China, of course, has the Yi Now phenomena, where a mob ransacks or vandalizes the hospital and extorts money in lieu of that violence which is created. And this phenomena is well recognized in China. The question which arises is mob violence spontaneous or is it orchestrated? You have to realize that mob violence is nearly always orchestrated. It does not happen spontaneously. The individuals in the crowd, they lose their sense of individual self and personal responsibility. The animal nature of man comes forth. There are people who believe in taking law in their own hands, and a feeling of immunity from punishment is there. And this very clearly demonstrates the trust deficit between public and the legal machinery. In China, we have this Yi Now phenomena, which I referred to earlier. But in India, the phenomena may be similar to some extent to the Yi Now phenomena, but it is different in the way that the mob violence is mostly to flex political muscle and is done by usually small-time local politicians, religious leaders, caste champions, and goons, even though seeking ex gratia compensation may also be a part of the agenda in some cases, like in Yi Now phenomena. We have incidents, especially this was a report from, if I remember correctly, Calcutta, where a family of 4 or 5 members was hired specifically to act as protesters in various hospitals where a patient, if died, had a substantial bill pending, and this family members would go with a crowd and create a ruckus in the hospital and demand waiver of the pending bill, and 25% of that amount these people used to charge for organizing the violence. This case had gone to the High Court and bail was denied in this case. Organized mob violence or WhatsApp lynches. You have to realize that it is not an easy job to collect 200 people. And to collect this kind of mob, the mass SMS or WhatsApp tools are remarkably useful in organizing this. Violent mobs in India may have gotten inflammatory messages from these social media, but the license to maim and kill comes from long-standing cultural divisions and government failures. Hundreds of millions of people are exposed to inflammatory stories online, but a vast majority of them do not indulge in stoning their neighbor to death. So these kind of WhatsApp messages may be occurring in other spheres also, but in this case, to a specific targeted population, they result in mob violence in hospitals. So what should be done? What should the hospitals do? I always say that there are 4 or 5 separate areas this issue is to be discussed in. What are the steps that can be taken by a hospital before any adverse event has happened? Definition of adverse event is, let us say, a sudden death in operation theatre in a young person. Then what are the steps once an adverse event has happened, but before the mob gathers? Then steps after the mob gathers, but no violence has yet occurred. Number 4, what are the steps once?
Dr. Nagpal, you have not shared your slides?
नहीं sir, नहीं, slide नहीं share कर रहा है इस बार.
Okay.
Steps when mob violence occurs and steps after mob violence. So these are the 5 areas I would like to discuss. For the issue of what are the steps to be taken before an adverse event, the training of the staff, this is one of the first things to be done, and there has to be standard operating procedures. Develop an SOP in case vandalism occurs, train your staff, conduct mock drills on a regular basis, and an SOP is something which describes the activities necessary in a particular situation. Number 1, who will inform other staff members and get them to the place of incident and how? Number 2, who will inform the police and how? Who will inform doctor colleagues and how? Who will videograph the incident and how? Who will secure medical records and how? Who will lock vulnerable areas and isolate them and how? All these things have to be pre-decided, pre-fixed, and they cannot be left at the last moment for everybody to follow. The persons who have to do individual tasks have to know their tasks beforehand, and this can only happen if you have a standard operating procedure or a drill. You have to learn from the corporates. Yes, you regulate the entry of visitors. There should be soothing environment, public relation teams. You have counselors, assistant managers, security people. All these things help. But the fact remains that we also need to identify and tackle the organizational risk factors. Working when understaffed. This is a very crucial thing, and specific working hours have to be identified when you are understaffed, like during meal times or visiting hours. Then if there is high worker turnover, what happens is you have trained in the SOP particular set of workers, but if the workers keep changing every 2 or 3 months, then the people on duty may not be acquainted with the SOP which you have conducted 1 year ago. Inadequate security, long waiting for patients and overcrowded, uncomfortable waiting rooms, unrestricted movement of the public in clinics and hospital, and perception that violence is tolerated. Of course, you should be on good terms with the local station house officers, with the local police, be on their first name basis. You should have good contacts with local branches or local organizations which are affiliated to various political parties. You should attend social community functions and participate as an establishment, regularly attend religious functions in your area, and also have good relations with your local professional organizations. Besides this, you also need to do worksite analysis. You have to have workplace adaptations to minimize the risk, have panic buttons or paging systems at workstations, secure the furniture, which can be used as a weapon to floor or wall, exit routes where possible. Rooms should have 2 exits, and provide the staff with a safe room for emergencies where the staff can simply go into the room, lock themselves up, and the door is strong enough to withstand any kind of forcible entry. CCTV monitoring, of course, all this needs to be done before any adverse event has taken place. So now let us discuss what is to be done once an adverse event has occurred, once you have taken a patient up for surgery, and this is a young patient and there is an unexpected death on table. Now, in this scenario, there are a number of things which can go wrong, but what you can do is do not panic, do not declare death immediately. Supposing at 12 o'clock, you have decided that yes, the person is not revivable any further. You have in your mind, you know doing the CPR or continuing the ventilation is not going to help. But even at that time, do not declare death immediately. Seal the OT door so that no one goes in or out. There should be no panicky young staff nurse running out of the operation theatre to get something. Do not declare death, but continue with resuscitative measures like cardiac massage and ventilation done by juniors, trainees, nurses for the next 15-20 minutes. Complete your medical records during this time, anesthetist notes, surgeon notes, nurses notes, mention all doses of all drugs used and mention at what time they were given for the anesthesia as well as resuscitation. Clearly document when fibrillation or asystole or hypotension was noted and that steps were taken to reverse the same. Sign all the records. Time of death should then be declared and noted at 12:20 p.m., during which time you have recorded everything in the file and made copies of the record. Preserve all medicine files also. Please remember, when suddenly something like this happens, you will be emotionally incapacitated, your mind will not function properly, and remember that a loose statement, comment, or record can have disastrous consequences when concerned with the relatives who you go and tell them that this kind of a thing has happened in the operation theatre. Telephonically or physically consult your seniors, inform your medical superintendent, ask for security, and police is to be informed in all cases where cause of death is not known with a request for postmortem. This also to some extent helps if violence is anticipated, and corroborative statements should be given, which are to be given to the police, should be prepared in advance. You know, in this kind of a situation, you are going to involve the police for the postmortem, so you should prepare the statement from the medical record and with the advice of seniors immediately, and then everybody should be giving same kind of statements. They should not be contrary to one another. Hospital records should be in indefinite safe custody of all medical records should be secured. Any incomplete records should be completed before anything is done. Get all concerned, including nurses and doctors, to write down their notes in file. Plus, counseling at this stage and the role of counselors cannot be overemphasized, because ultimately this is the time where communication is going to come into play. But then the communication will help if the patient or the patient's immediate relative is to be counseled. If there is a mob of 200 people, there is no role of this kind of counseling. And then all the techniques which we advise the doctors should use for counseling become totally useless. Announcement of this bad news must be in straightforward terms. It should be done by consultants. It should not be left to junior doctors or to young nurses to declare death of this kind of a situation. It should be done in a proper room where proper facilities are available, in the presence of witnesses, in the presence of other staff members. Another major problem which occurs at this time and which incites violence is the bill which is pending of that patient. So what we suggest is prepare your bill. While giving death summary, get this bill copy signed by the relatives or next of kin. Do not insist on payment of bill before releasing the dead body. This is one thing which should never be done. It very frequently escalates the problem. Provide proper respectful care for the deceased, wrapping the body in clean sheet. Provide an ambulance to transport the dead body. Assume that the patient party will file a police complaint and prepare a common statement from medical records and with legal help if you have in-house legal help available. All statements given thereafter to the police by the anesthetist, surgeon, OT nurses, technicians should corroborate with each other. Number of people ask me, is it mandatory if there is a sudden death on table for police to be informed? Let us go to the judgment of Renu Jain versus Escorts Heart Institute. This has held very clearly that autopsy is a must in case of sudden and unexpected death. In facts and circumstances of the case and scenario leading to sudden and unexpected death of patient in operation theatre, autopsy ought to have been held, and not having held autopsy is a factor which is equitable to deficiency of service. This judgment has been quoted, and the same spirit of judgment has been given in many other cases. So what happens now? You have declared the patient dead. and there is a mob which collects, but violence has still not occurred. At this stage, what you need to know is something which in Harvard, a political scientist, Mr. Wilson and George Killing, both of them introduced. They said there is something called a broken window principle. Broken window principle means when somebody does a minor crime and you ignore it, it leads to an environment which is conducive to more serious crime. So when somebody is verbally abusing or low-level battery has been there and no reaction has, the hospital ignores it, in other cases, it encourages more incidents of violence. You have to have good counselors, good people who can identify from the behavior of people, from the behavior of the mob, whether or not this is going to indulge in violence. There are many techniques. Stamp is one of them, but too detailed to go into that right now. So you should anticipate violence. You should remain calm. De-escalation techniques are known which can be used, but usually in the face of a mob, the only thing which probably helps is collect doctors, friends, security people, have a number of people with you, which provides a non-verbal communication to the patient or the relatives that violence on the part of the patient party will not be an acceptable behavior. Yes, you need to de-escalate the situation. There are again a number of communication techniques to do that. You should not be in a rush to communicate and get it over with. So what should you do once you have done everything to prevent but mob violence occurs in the hospital? If mob violence occurs, your first priority is protect yourself. There is no bigger priority than that. Protect yourself, prevent physical injury from happening to yourself and to others. Contain and isolate the area of violence. Containment of the violence into the area where it has originated, not allowing it to spread throughout the hospital or throughout the ICU or in other places in the hospital is of utmost importance. Video record the violence, protect medical records, inform authorities, police, security, colleagues, press panic button if it is available, remove yourself from the situation, lock yourself in safe room, call security for help. But always try to keep an open path for exiting. You should not get trapped into a situation where you are in a room and 10 people are blocking the door, the only exit to the room. It is better that when the hospitals are designed for these kind of counseling chambers, there are two doors so that a person can exit. As I said, for SOPs, you should have someone designated beforehand to take photographs, even audio records of the violence, and depute someone to immediately get the medical record of the patient photocopied. If mob carries away the original record, the photocopies will be useful. And of course, you need to file an FIR for stealing the medical records. Inform your advocate, inform the police, identify troublemakers, leaders. The problem in India is this type of mob violence is very unique in India. To some extent, some incidents have occurred in Bangladesh and Pakistan, but usually there is a low-level political leader who is wanting to come into the social or the political limelight, who organizes this kind of violence. Hospitals are very fertile grounds to gain notoriety, emotionally charged atmosphere, death, hospital pending bill, low risk, low investment. Any violence conducted in hospital, there is no retaliation from the hospital sides. So people who are indulging in this are confident that they will not be taken to task. No retaliation is there, guaranteed publicity in local press, and chances probably of getting a ticket in the next elections. We have a lot of inspections and videos which are seen on TV of inspections of hospitals during working hours by politicians and berating doctors in front of patients. This kind of thing gathers some votes for the politician, but transforms the doctor from a person of authority to a vulnerable, guilty non-entity. shouting at doctors publicly leads to accompanying people, maybe journalists, to accept that this is acceptable behavior. Look at that incident which became viral, Anjana Om Kashyap from, I think, India Today or whichever news channel she was in Muzaffarpur, in an ICU during the outbreak of Japanese encephalitis. She is shouting at the doctor and she is grabbing all the attention and all the video footage, not allowing the doctor to look after the patients currently admitted there. This is something which is considered acceptable because it raises the TRPs of the channel concerned. So what should you do after violence has occurred? First of all, send all staff and doctors to nearest government hospital and get their MLR prepared, secure a copy of the same, lodge FIR with the police, and specifically mention that FIR will be lodged under the Prevention of Violence Against Medicare Services Institution Act of the state. Give copy of the act along with the complaint, because the police fellow will definitely tell you that he has no idea what this act is all about and he understands only IPC. Attach a copy of CCTV footage with the complaint. These prevention of violence acts have been paper tigers for a long time now, maybe around 10-12 years. And effectively, they have not been a deterrent for violence which has been occurring. The most important part is once patient party or these kind of mobs indulge in violence, they get the patient relatives to go and file a cross FIR. Once the hospital files an FIR for violence, they also go and file an FIR claiming criminal negligence has occurred in that incident. Now, in this kind of situation, police is very happy because both parties have a cross FIR against each other. They make the people sit and try to withdraw the complaint of violence and maybe give some settlement amount to the patient party. So effectively, the incident of violence goes unpunished and it encourages more people to indulge in more violence. Whereas, if you go to the Jacob Matthew judgment and there was Muhammad Ishfaq judgment, it was very clear that police officials cannot lodge an FIR without a medical board's opinion in cases of doctors. Well, this is again a long topic, so I will not go into the details. Suffice it to say that police officials routinely do not obey the Supreme Court guidelines, and at times from senior officials, I have even heard that they are not concerned with Supreme Court guidelines, they are concerned with IPC and CRPC, and they will follow that, and that does not mention any special treatment to be given to any special group in the society. So remember, as a victim of violence, you have a right to press criminal charges, and this non-reporting culture is something which creates grounds for more violence to occur, maybe in your own hospital. After the incident of violence, there has to be a debriefing, and in debriefing, the entire incident has to be discussed with all the people who were involved. Was communication clear? Were roles and responsibilities understood? Was situational awareness maintained? Was workload distribution equitable? What was the factors which led to the violence? Was task assistance requested or offered? Were errors made and or avoided? Were resources available? What went well and what should be improved? This kind of cathartic effect, when we have these kind of debriefings, it is a cathartic effect which the staff unloads and gets to discuss what they have, what has happened and how this can be prevented in future. Of course, the short ways to prevent violence are to retire. You will also need to tackle the media, and the media, to tackle them can be extremely difficult. Always better to have your legal representative sit with the doctors involved in the incident and already prepare a kind of a press release which incorporates all the relevant data, because at odd times, different people should not be answering questions of the press reporters. All such queries should be directed towards one person who should be the representative of the hospital, and he is the one who should give press releases. There is no reason. We have come across incidents where reporters have rung up doctors at 1:30, 2 o'clock at night, claiming that they have the relatives of a patient who has died sitting with them, and that the doctor should pay 5 lakhs, otherwise the news will be published the next day. This is something which is nothing else, nothing other than blackmail. And I personally do not recommend doctors to indulge in these kind of blackmail activities, to fall for these kind of blackmailers. When you discuss with the press, do not give a statement like no comment. Proactively involve the press. All press statements should have uniformity. Anybody rings up, you have to document the name of the person, the email address of the person, the mobile number of the person should be with you. Tell them that you are sending your statement to them by fax or by email immediately, so that they cannot deny that they have not received your press release. This person who is nominated by the team to face the press is somebody who should be experienced, who should have some knowledge of the law also. When you are suddenly confronted with a TV camera crew, try to maintain your professional composure. The film or the picture which they are likely to use is something which will leave the impression in public mind. Focus on where you are going. Do not look directly into the camera. Do not cover your face or react angrily. But do not smile also in the camera, because that smiling may convey a wrong message. And remember, this will be the image which is viewed by the public. Keep your statements short and factual. Ideally, 150 words is the general guide. Why I say 150 words? Because column inches, when the press is publishing, is limited, and when the editor is trying to fit in your press statement into the columns which he is to print next day, he could remove too lengthy a statement, could be distorted, and the meaning which you wish to convey may be totally opposite from what is finally published. And still, after all these precautions, next day when you get up and you open the newspaper, before opening the newspaper, always advisable to take half a tablet of sorbitrate. Then number of people will advise you after the incidents of violence to compromise, especially the police. This is something which usually I do not recommend, because we have number of cases where this kind of a compromise has been done, and the agreement of compromise made between parties has been taken as proof that negligence had been committed, and it has been taken to court on the basis of that kind of an agreement. Another thing, please remember, a compromise does not help in the criminal case. The criminal case is the accused versus the state. The complainant does not have any role thereafter after bringing the matter to the notice of the police. So the criminal case does not help in even if you compromise or you settle with the patient party. We have judgments on this, but then again we are going short on time. So you will also be facing social media defamation, so need to tackle that also. Unfortunately, the Section 66A Information Technology Act has now been struck down by the Honorable Supreme Court, but you need to pursue the matter and look at this case where Aditya Birla Hospital, Pune, they pursued a patient party who had defamed them wrongly on social media, and the patient party was directed to pay 1,03,89,795 rupees with 18% interest. So also always assume that a consumer case will be filed later. Based on medical records, take statements from all team members, preferably as affidavits. Some staff members would have left the institution when the case comes to court. Publicly form an inquiry committee of senior doctors not involved in the treatment of this patient, including some, if possible, from outside the hospital, and let this committee give its findings and give a copy of this as part of the reply later to be filed in consumer courts. Thank you so very much. I hope I have not exceeded my time. this was the main reason I did not use the slides today. Yes. Am I audible?
Dr. Nagpal, thank you very much. This was a very exhaustive topic that you concised it very much and we did not feel lack of slides as the lecture was very involving. Thank you very much. Now our second uh, speaker is Dr. Rishi Bhatia. Dr. Rishi Bhatia, you please unmute yourself first and then you share your slides. Dr. Rishi Bhatia is a surgeon from Meerut. He is an alumni of MLB Medical College, Jhansi. Did his MS in general surgery. He did his LLB from Meerut University, Meerut. He did his PG diploma from National Law School of India, Bangalore, and diploma in hospital management from National Institute of Health and Family Welfare, New Delhi. He is a laparoscopic surgeon and a medical legal consultant. His medical legal advice, he is also medical legal advisor to UP IMA, UP Nursing Home Association, and is past president of Indian Medical Legal Ethics and Association. Ethics Association. His topic for today is new in CPA 2019. Welcome, Dr. Bhatia. Please share your screen.
Am I audible?
Yes, you are audible. Just share your screen.
Thank you, Dr. Sirohi, for your nice introduction. And I thank the organizers for giving me opportunity to say something about new in Consumer Protection Act 2019. Although there are many changes in the Consumer Protection Act 2019, but I will confine to the only relevant part which is effective to medical profession.
Dr. Bhatia, please. Yes. Now the screen is good. Go on, sir.
This new Consumer Protection Act came in effect from 20th July 2019. It was passed in Lok Sabha on 20th of December 2018 and was passed in Rajya Sabha on 6th of August 2019. And the Gazette publication was done on 19th August 2019, and rules have been recently notified on 15th of July 2020. In the new CPA, the term for district forum has been changed to district commission. State commission and the national commission, the terminology is the same. Now the complaint can be filed electronically, that is by email. And the commission can hear the issue by video conferencing. That has made very easy for the complainant to sit at home and do video conferencing. On application complaint to district commission, if there is no order within 21 days, it is deemed admitted. Now a new thing has come in the commission, mediation, which I will tell you later in detail what is mediation. If both parties agree, then the case can be referred to mediation. The commission has to decide the case within 3 months, although practically it was not being done earlier also, but it says that the case should be decided within 3 months. And the commission can review its own order within 30 days. Earlier, the president of the commission was a judicial member. Now, anyone, even a political leader, can become president of the commission without any judicial background. The services covered are telemedicine also, advertisement by website, electronic network. And a very new thing, any person who is even not the member of any consumer association can file bill through a consumer association in the commission. Public interest litigation was not there in the consumer forum, but now anyone can file public interest litigation through a consumer association. The territorial jurisdiction, earlier the complaint was lodged where the incident occurred, where the hospital was situated, but now the complaint can be lodged from the residence of the patient. If a patient got treatment in Delhi and resident of the Chennai, that he or she can file the case in Chennai. And if the person want that the jurisdiction be changed from Chennai to Delhi, it cannot be done. It can be transferred within the state only. And the power to transfer the case from one state to other lies with the National Commission only. Pecuniary jurisdiction, earlier the pecuniary jurisdiction was 20th lakh for the district forum, and that was the amount claimed. Up to 1 crore state commission, that was the amount claimed. But now the amount of the district commission is up to 1 crore paid for services. If the patient has paid 20 lakh and has claimed 80 lakh, then it will be within the jurisdiction of the district commission. Similarly, state commission, the jurisdiction of paid services will be from 1 crore to 10 crore. In National Commission, it is beyond 10 crore. And moreover, if the patient has paid less than 5 lakh, then no fee for the complaint will be charged. There will be free services given by the commission. There were multiple punishments earlier, and now 3 more punishments have been included for the medical profession. One is unfair or restrictive trade practices, second is unfair contract, and third one is negligence deficiency in services in a different way. Unfair or restrictive trade practices, if you fail to issue a bill or receipt, then it will be unfair trade practice. And moreover, they have given a format for the receipt. It is not your own style of format. They have given a prescribed format in which you have to give the receipt. If you manipulate the price or charges at the time of admission, if you say something and the charges increase because of other reasons, and you increase the charges, increase the bill, then it is also the unfair trade practice. Excessive billing or pricing is an unfair trade practice. If you disclose some information about the patient to others, not to the patient, then it is breach of confidentiality and it is unfair trade practice. It is punishable now under Consumer Commission. Unfair contract, the contract will be null and void if you ask the patient for excessive security deposit at the time of admission. If you transfer the contract to a third party without consent of the patient, if you get operated from the person for which you have not taken the consent, you involve the other doctor for which consent has not been taken, it is unfair contract. And if you stop the treatment of the patient, or if you refuse without giving any reason, you terminate the contract, then it is unfair contract. A new type of negligence deficiency services include if there is deliberate withholding of relevant information about patient which cause harm. If you don't inform the patient about your treatment part, follow up at the time of discharge, then it becomes negligence in services. And if you have not given sufficient instructions to the patient or warning for any harm to the patient, then it is also negligence in the services. Earlier, there was penalty for frivolous or vexatious complaint, which has been removed in the new act. For non-compliance of commission, there is imprisonment for 1 month to 3 years or fine from 25,000 to 1 lakh or both. Appeal. If the case has been decided by mediation, there is no appeal anywhere. And for going to appeal, you have to deposit 50,000 amount awarded. And in National Commission, if you go for appeal, then you have to prove that there is substantial question of law. What is mediation? Mediation is a consumer mediation cell which has been formed for every district, every state, every national commission. It will be consisting of panel of mediators which will be selected by the respective commission. From the panel of mediators, a group will be formed where the case will be referred for mediation. On filing case, commission would refer for mediation if both parties agree and they give consent within 5 days of direction of the commission. And if they consent, both the parties consent, then commission will refer for mediation within 5 days of giving the consent. On settlement, whether it is partial or complete, the mediator would submit the report to the commission, and then commission will pass orders within 7 days of submission of their report of the mediators. If there is settlement reached by mediation, the fee deposited will be refunded. But there will be no mediation in criminal cases. And there will be no mediation if there is medical negligence resulting in grievous injury. And during the pendency of the case in mediation, there will be no proceeding anywhere else. And if the case is settled by the mediation, there will be no appeal in any commission. A new authority has been formed in the new act, named as Central Consumer Protection Authority. This central authority has been established with effect from 24th of July 2020. That would deal with the complaints and investigations for violation of consumer rights, unfair trade practices, false or misleading advertisements. This authority would consist of Chief Commissioner as a head, then commissioners, regional commissioners. It will have an investigation wing, which will have Director General, Additional Director, Joint Director. Complaints can be lodged with any of the above authorities. And now the complaint can be lodged directly to the district collector, district magistrate. And the above authorities, which are in the Act as a central authority, all authorities can refer the case to district collector. And they can send their complaint to these authorities by email. Central authority can start inquiry on complaint or on direction of the central government, even suo motu. Without any complaint, they can start an inquiry against any consumer, any victim. The doctor need not to get complaint from the patient, from media reports or from other information. Central authority can start inquiry suo motu. This central authority will file complaint to any commission, district commission, state commission, or national commission, and this central authority can intervene in proceedings before any commission if there is any case going on in district commission, state commission or national commission, this central authority can intervene itself. And this central authority can refer the case to medical council, now known as National Medical Commission. For search and seizure, more powers have been given. Any person authorized by these authorities can enter your premises to search and seize any document. Even district collector or director general can enter your premises to seize the case sheet anytime. Appeal against central authority lies only in the National Commission within 30 days. For non-compliance of central authority, there is imprisonment of 6 months or fine of 20 lakhs or both. Now, because of all these new things, the cases would increase because of e-filing, video conferencing, hometown jurisdiction, deemed admission after 21 days, pecuniary jurisdiction rupees 1 crore, because hardly there is any treatment where the bill of the patient goes beyond 1 crore. So most of the cases would lie in the district commission. And there is no fee for expenditure for bill given to the hospital up to rupees 5 lakh. If a patient is giving less than 5 lakh, there will be no fees for complaining in the consumer commission. And there may be complaint to the direct district collector or central authority. So number of cases would increase due to this. And so there will be increase in the cost of indemnity insurance, hospital bill, professional services, medicine, medical devices. Thank you. Thank you for kind listening.
Thank you very much, Dr. Rishi. There are many questions pertaining to this 2019 bill, which we will take in the end of the session. So get prepared. Now, our third speaker is Dr. Anurag Verma.
Let me exit.
Dr. Rishi, please get your screen out. Dr. Anurag Verma, you may share your screen. Dr. Anurag Verma,
Yes, sir,
MD Medicine, LLB, is physician and medico-legal consultant at Kashipur, Uttarakhand. He is an alumni of SN Medical College, Agra, an associate professor of law at SD College of Law, and an executive member of Indian Medico-Legal and Ethics Association. He has also done PG DLMA from Pune. He has a passion for medicine and law both. Welcome, Dr. Anurag. His topic for today is telemedicine, relevance and limitations. Dr. Bhatia, आप स्क्रीन से एग्जिट हो
Yeah, I have shared my
yes,
good evening to all of you.
it is seen.
Talking on telemedicine, it's
A little louder, Dr. Anurag.
now am I audible?
You are audible, but a little loud.
Connection is okay. I'll be talking on telemedicine. It's not a new concept, but now the telemedicine guidelines have been issued. So law, as far as law and regulations are concerned, these have become a bit clear now. 25th March 2020 was a historic day when telemedicine guidelines were released by the Board of Governors in supersession of MCI under Niti Aayog. On 14th of May, these guidelines have officially been notified and gazetted. Now, eligibility requirements shall be granted to RMPs to regularize their practice of telemedicine. The only missing piece is e-pharmacy draft bill that is pending. These telemedicine guidelines, should I take this? These telemedicine guidelines will help realize full potential of the advancements in technology for healthcare delivery. Rural and remote population is to benefit the most, and our health indices are expected to improve in the long run. Till now, as I already told, in the field of telemedicine, gaps in legislation and uncertainty of rules posed a risk for both the doctors and their patients. Now, consultation through telemedicine by RMPs under IMC Act shall be permissible in accordance with the telemedicine practice guidelines. It will ensure medical practitioners that telemedicine consultations are legal now. The release of the regulations, which were in pipeline for some time, is seen as a timely intervention in context of COVID, when healthcare services are limited and hospitals are trying to decongest spaces to prevent cross-infection and ensure the safety of healthcare workers.
Dr. Anurag, your screen is not moving. Okay.
Sir, it is moving now?
Yes, now it is moving.
Is it not moving?
It is moving now.
Yeah, that was an introduction, sir. Now I have.
Okay.
Okay, sir. So by definition, the delivery of healthcare services where distance is a critical factor by all the healthcare professionals by using information and communication technologies for exchange of valid information for diagnosis, treatment, and prevention of diseases and injuries. Telemedicine also includes research and evaluation and for continuing education of healthcare providers, which are kept at exclusion for the moment. In India, till now, there was no law or guidelines for telemedicine. Every existing provisions of law, for example, under IMC Act 1956, MCI Code of Ethics, Drugs and Cosmetic Act 1940 and Rules 1945, Clinical Establishment Act 2010, and Information Technology Act, they do not mention actually any detail about anything about the practice of telemedicine. What was being practiced was only indirectly applied to any practice that was happening. Gaps in the legislation and uncertainty of rules pose a risk for both doctors and patients, as I've already told. Now, the purpose of these guidelines is to render practical advice to all the medical practitioners and integrate telemedicine into the normal practice. It is also to ensure the correct course of action for providing effective and sound medical care is adopted by the doctors. These are meant for, guidelines are meant for RMPs under IMC Act or in Medical Council Act 1956. It covers, these are to be taken as norms of practice by the RMPs until this law is amended and these the RMPs are made eligible after passing online examination. This includes all channels of communication, for example, video, audio, text, and digital data exchange. Certain exclusions are there in these guidelines as far as telemedicine is concerned as such. These are specifications for hardware, software, infrastructure and maintenance, data management systems, standards and how they will become inoperable. Surgical and invasive procedures are not allowed, which are to be done remotely by the RMPs who are using telemedicines. Then other aspects of telehealth, research and evaluation, continuing education of the healthcare workers, these are also kept as exclusions. And a very important thing is that it does not provide for consultations outside the jurisdiction of it. An online program will be developed by the Board of Governors in the coming days and examination within 3 years of notification, and then they will be to practice the telemedicine. Then there are ways how the telemedicine practice can be adopted and can be practiced by the RMPs. It can be telemedicine can be practiced on telephone, video, devices which are connected over the local area network or wide area network or over the internet. Over the chat platforms like WhatsApp or Facebook Messenger can be used. Data transmission systems like Skype, email, fax, etc. these can also be used. Telemedicine applications have 4 basic types. Number 1, it is what is the mode of communication, and according to time of information which is transmitted, whether it is transmitted instantaneously or some time lag is there, then what is the purpose of consultation of the patient, then individual who are involved in consultation. Now, according to the modes which are used for telemedicine, these can be various types. For example, these can be video telemedicine facility in, it can be apps in smartphones, it can be through Skype or FaceTime, etc. As far as audio is concerned, it can be through phone, VoIP, apps, etc. It can be text-based also, telemedicine chat-based applications. For example, apps, websites, or other internet-based systems can be there. It can be through general messages also, like text messages, chat platforms, for example, WhatsApp, Google Hangouts, or Facebook Messenger can be used. Asynchronous, for example, it can be asynchronous as far as time is concerned, and it can be through email or fax, etc. Then, depending on the time at which the information is transmitted from patient to doctor or other side, it can be real time, as with audio, by video, or it can be asynchronous also. If the images are they are uploaded and sent by fax or email, and these will be viewed by the doctor after some time, and then he will give his opinion as far as diagnosis of medication or health education or counseling is concerned. As far as purpose of the consultation is concerned, it can be divided into first consult or follow-up consult. First consult in telemedicine means that the patient is consulting the doctor, or the doctor is giving advice to the patient for the first time, or a period of 6 months has lapsed from the previous consultation. It is second consultation is after 6 months, or it can be earlier than 6 months, but it is for a different health condition. Then it will be considered as first consult. Then what is follow-up consult is that it is within 6 months for the same health condition. If a person is discussing with the doctor or consulting the doctor for the same health condition within 6 months, then it will be taken as follow-up consult. Now, who are the individuals who are involved in this interaction on telemedicine? This can be an interaction between patient to the registered medical practitioner, or it can be a caregiver who is consulting the doctor on behalf of the patient, and he has taken consent from the patient. And this is an interaction between the caregiver and the RMP. And caregiver can be any person. He or she can be any family member of the patient or any other person who has been authorized by the patient to take advice from the RMP on his behalf or her behalf. But for consultation between RMP and caregiver, an explicit consent of the patient is very much required. It can be an interaction between healthcare worker and the RMP. Healthcare worker is very important in the sense that he can help by taking proper history, and up to certain extent he can do examination, and he can also explain the advice of the RMP which is given to the patient. So healthcare is role of the healthcare is quite important in telemedicine. Now, what is the methodology which is to be followed for management of a patient by telemedicine? It is a clinical judgment of the doctor that whether it is right to give telemedicine advice to a patient or not. If he thinks that it is not up to the mark, or the patient will not be benefited by telemedicine advice, then he can ask the patient to take in-person consultation. And the advice or this situation which is to be handled by the doctor, the judgment of the doctor should be in the best interest of the patient after taking a holistic view. Now, the telemedicine consultation is not to be anonymous consultation. Means that the persons who are interacting, they don't know each other. Identity of the patient as well as identity of the doctor must be disclosed to each of them. As far as patient is concerned, name, address, email ID, phone number, or any other registered ID or any other identification of the patient should be known to the doctor. Same way, the credentials and the contact number or the contact details of the doctor should be known to the patient also. If doctor is proceeding for telemedicine advice and he wants to give a prescription, in case of a minor, the identity of the adult should be there and who should give consent on behalf of that minor patient. Then registered number of RMP on prescription website with which he's acting, or the electronic communication platform should be there, and whatever receipts is issuing to the patient, registration number of the RMP should be there on those receipts also. Then about the mode of telemedicine, appropriate type of technology should be used. Among three modes, namely audio, video, and text, they should be used as per their appropriateness for diagnosis and treatment. As far as issue of consent is concerned, consent is also mandatory in case of telemedicine consultation. Consent can be either implied or it can be an explicit consent. Implied consent is when the patient initiates consultation, when he gives a call to the doctor and he says that I want to consult you by telemedicine for such a situation or such a disease, then that means that the patient is giving his implied consent. Explicit consent is needed when the health worker or RMP or caregiver, he initiates a consultation on behalf of the patient. And a method of taking explicit consent by the doctor should be, which has been suggested by a number of experts, that the doctor should say that I am an expert who give advices by telemedicine, and you are here to take my advice, and I will do for you, I will advise you as the best I can do for you, for your interest, and would you like to take advice from me? If the patient says yes, then this will be an explicit consent given by the patient. For explicit consent, otherwise, patient can send email, text, or audio or video message also. All these things and the consent should be recorded in the patient's record by the RMP. Now, the RMP is to use professional discretion to gather information by history, investigations, past records to exercise proper clinical judgment, if that is the case. If RMP feels information is inadequate and further investigation is needed, then he may pause the consultation and he may advise to the patient that certain investigations are needed or certain informations are needed. And when you will get these messages or these information furnished to me, then I will resume the talk, and this talk can be rescheduled. If a physical examination seems to be must, then an in-person consult is to be advised by the RMP. Whenever necessary, as per professional judgment, RMP should recommend for video consultation, for examination by another RMP or health worker, or for in-person consultation, and the RMP shall maintain all the records. If the RMP is of the opinion that the condition of the patient is manageable by telemedicine, then the RMP shall proceed with following advice based on his professional judgment. If there is need for health education, then he will advise the patient as far as disease prevention is concerned, for the appropriate diet, physical activity, leaving smoking, immunization, hygiene practices, mosquito control, etc. And if a particular specific disease is there, then counseling of the patient can be done by the RMP, and it is to mitigate the disease. And it may include new investigations also, and patient is expected to get it done. How the medicines can be prescribed by telemedicine. It is at the professional discretion of the RMP. And whenever same professional accountability as he has to entail in-person consult. Same protocol if health condition for investigation treatment as in even he is satisfied to have gathered adequate and relevant information and prescribed medicines are in the best interest of the patient. Otherwise, he will not prescribe. Prescribing medicines without an appropriate diagnosis or provisional diagnosis will amount to a professional misconduct. As these telemedicine guidelines were not announced at the time when this case of Deepa Sanjeev Pavaskar versus state of Maharashtra was there, and many of the medical practitioners, they actually misconstrued the judgment of the High Court that it was a case of criminal negligence. It was not because the advice was given on telephone, but court had said in this case that the advice was given on telephone without a proper diagnosis. Had this case happened after the telemedicine guidelines been issued, then it would have been a case of professional misconduct, may have been there instead of criminal negligence. Now, what are the categories of medicines which can be prescribed by telemedicine? There are certain specified drugs which can be prescribed, and certain drugs are not to be prescribed. There are four lists according to which the drugs can be prescribed. In this list, medicines which are safe to be prescribed through any mode of consulting, and these are the drugs which are ORS packages, cough lozenges, etc. And medicines which are deemed to be necessary during public health emergencies. Then there is list A, and it includes the medicines which are to be prescribed during the first consult, which is a video consult, and are being prescribed for refill in case of follow-up. And these are various medicines like ointments, etc., which can be given by the doctor by seeing the condition of the patient on a video call. These are the medicines which are having low potential for abuse. List B contains the drugs which are to be given in case of follow-up, in addition to drugs which are prescribed during the in-person consult for the same medical condition. Then there is a prohibited list, in which list the drugs which cannot be prescribed via telemedicine. These are the medicines with high potential abuse and may harm the patient and society at large. Narcotics drugs and some of the sedative drugs were not to be prescribed, but recently for psychiatrists, they can prescribe certain drugs, and 3 drugs have been added to this category, and these are phenobarbital, clobazam, and clonazepam. And these are the medicines which are listed in Schedule X of Drugs and Cosmetic Act and Rules 1945, and Narcotic Drugs and Psychotropic Substances Act 1985. After the consultant or the teleconsultant has prescribed medicines, he shall issue a prescription to the patient, and a sample format is suggested in Annexure 2 of this telemedicine guidelines. The RMP shall provide photo, scan, or digital copy of a signed prescription or e-prescription of the patient via email or any messaging platform. If prescription is transmitted to a pharmacy or e-pharmacy, which is not at the moment in India, but in foreign countries, directly the RMP, who is advising medicines by telemedicine, he can transmit the prescription to the pharmacy, and patient can get medicine from that pharmacy. But in this case, the explicit consent of the patient is very much required, that from which pharmacy he wants to take medicines, and otherwise to which pharmacy the consultant is sending the prescription. If he agrees to that, he may collect the medicine from there, or the pharmacy can supply the drugs. RMP may charge a reasonable fee for telemedicine consultation. But in case, and obviously, if he charges the money for consultation, then he will have to give a receipt to the patient. Now the question of emergency situation arises. If it's an emergency situation, as per judgment of the RMP, then he should aim to advise the patient for an in-person consult at the earliest. Advice to the patient in these cases, which he thinks in emergency, should be limited to advice for first aid and for life-saving measures. For example, giving sorbitate in a non-cardiac patient who has got chest pain, or in case of injury, how the neck of the patient should be kept, like that. And it should be, counseling can also be done, and it should facilitate referral of that patient to the nearby medical practitioner for an in-person consultation. But if there is a situation when no medical aid in form of in-person consultation is available to the patient, then the doctor or the teleconsultant may advise the patient up to his best clinical judgment. He can advise also for medication if no other medical facility is available. Then there is a very important issue of medical ethics, data privacy, and confidentiality. Principles of medical ethics and protecting patients' privacy and data protection and confidentiality as per MCI Code of Ethics, relevant provisions of IT Act and data protection and privacy laws must be upheld and practiced. But RMP will not be held responsible if it's not negligent, if the breach of the data privacy has not been there from the RMP side, then he will not be responsible, and it may have been done because by the electronic platform or the telemedicine platform, or by any other anonymous person. In that case, the RMP will not be responsible. And in this case, the provisions of Data Protection Act 1991 and Information Technology Act 2001, those will apply. And in section 43A and in section 73A of the Information Technology Act, because that is an electronic platform, and that is an electronic platform on which the telemedicine practitioner is prescribing the medicine or advising, then this will also come into action. And these are the panel provisions of the 41A and 72A sections of Information Technology Act 2001 are having the penalties for this kind of breach of personal data. And then how the any act in contravention to the MCI Code of Conduct, which is a normal thing in case of medical practice, ethics, or there is a willful compromise in patient's care, privacy and confidentiality, or violation of any prevailing law, that is not permissible, and that will be treated as misconduct. If RMP is insisting on telemedicine while the patient requests for an in-consultation, this is a misconduct on part of the telemedicine consultant. If he misuses the data of patient and images, it is also misconduct. If he prescribes drugs from the restricted list, it's a misconduct. And to solicit the patient for telemedicine through advertisement or inducements, this is also. So these are the cases where it will be treated as misconduct of the telemedicine practitioner. There are guidelines for the technology platforms also who are enabling telemedicine. Medicine platforms or the technology platforms shall be obligated to ensure that patients are consulting with genuine RMP, who are duly registered and complying with relevant provisions. Technology platforms shall exercise due diligence for providing name, qualifications, registration number, and contact details of the RMP. They have to report any non-compliance to Board of Governors for appropriate action. Technology platforms based on artificial intelligence or machine learning are not allowed to counsel or treat the patient, but they can be supportive. They can be used by the telemedicine expert for support. A proper mechanism to address any query or grievance of end customer is to be ensured. And in case of violation of these norms, Board of Governors can blacklist any such technology platform, and the RMPs will not be listed on that platform. Now, what is the relevance of telemedicine in the present times? There is availability of healthcare to patients in rural or underserved areas without necessity to travel, and this can be very convenient to the patients as well as to their attendants. When traveling is not possible in post-disaster, natural calamity, or emergency situations, then the telemedicine assumes its importance. Telemedicine can be very useful in regular monitoring, where the patients, they don't have to come for an in-person consultation. That is not necessary in these situations, when only regular monitoring and follow-up of elderly patients and patients with chronic diseases is required. When there is a need for monitoring of drugs and dose management, for example, dose adjustments of antihypertensive drugs or dose management of insulin in case of diabetics, then the patients don't need to come to the doctor for in-person consultation, and these can be very well managed at home by telemedicine, by the teleconsulting. And this will save the time, and cost of the treatment will also be reduced. It also facilitates health education by allowing students and health workers to listen to experts. Medical teaching is possible by making available academic material and case presentations through webcasts and teleconferencing. Formation of computerized database and its study can improve quality of patient treatment. It will reduce burden of secondary hospitals also. For example, during the present time, the OPD load will be less, and the consultants or the doctors in the hospitals, they can divert their attention to the admitted patients who are more serious. So in this way, this will reduce the burden of secondary hospitals also, and the energies of the doctors can be utilized for more important tasks. There is higher likelihood of maintaining records, so better legal protection is there, because doctor will also keep the records, and the patient is also supposed to keep the record of the doctor. During times of epidemics, it shall protect the doctors and patients from cross-infection. So these are the relevant aspects of the telemedicine, but telemedicine has got certain limitations also. As compared with in-person consultation, there is always a possibility of missing an important finding. So there is always a possibility of some error. In case of a health worker who is doing examination of the patient, final treatment up to some extent is affected by his standard, how he examines the patient and how he transmits the findings to the teleconsultant. So in this way, some treatment will be affected, or the quality of the treatment will be affected by the standard of the healthcare worker. In certain instances, time taking to provide healthcare may be actually longer than the in-person consultation, because of the increased time to access and correctly treat patients in virtual interactions. It may be very harmful in emergency situations if an in-person consult is available. Technology issues can be disturbing. For example, there is slow internet and the patient is not able to transmit the information from his side, or the doctor is not able to explain himself, or not able to understand what the patient is saying. Poor quality of images and records and omission of relevant clinical information might affect quality of healthcare delivery. There are licensing issues also because of different state laws to allow telemedicine practice in their respective states. There is difficulty in claiming insurance and reimbursements, and there is always a possibility of misuse of the patient's data. So now I come to end of my talk, and I have I have detailed whatever I think these are relevances and limitations of telemedicine. Thank you very much.
Thank you, Dr. Anurag. It was a new topic, but you have explained it well. If there are some questions, we will see in the end. Now I would invite Dr. Govind Sethi. He is our last speaker for the day. Dr. Govind Sethi is an orthopedic surgeon settled in Yorkshire, United Kingdom. He is an alumni of MLB Medical College, Jhansi. After his post-graduation, he worked for a few years in Kanpur, Uttar Pradesh, along with late Dr. P.M. Gadre, the father of orthopedics in Kanpur. Then he left for United Kingdom and worked in many famous hospitals such as Callardale Royal Hospital, George Eliot Hospitals, and now he works as consultant in Callardale and NHS Trust in Yorkshire, United Kingdom. His main interest is lower limb arthroplasty, knee arthroscopy, and general trauma, including THR and fracture neck of femur. His topic for today is red flag signs and their medico-legal implementation in cauda equina syndrome. Welcome, Dr. Govind Sethi. The mic is yours.
Thank you very much, Dr. Siroi, and thanks to IMA Uttarakhand for having me in this webinar. It's a pleasure to be talking to you guys, and also a lot of people who are just as a virtual attendees. I gather you had asked me to give a talk, so I thought nothing better than talking about cauda equina syndrome, which has got some relevance with medico-legal aspect, and that's what it is all about talking about today. Now, cauda equina syndrome carries a lot of morbidity if somebody gets. It's not a very common problem. If you look into this, various literatures would say it's 1 in 100,000, which does go up over the period of time as people start getting older. Between 30 to 50 years, it can go up to 7 per 100,000. Why it's important? Because the morbidities what you get after that are enormous, and it affects patients' livelihood. So what is cauda equina syndrome? I'll be talking a minute for each slide just to let you know what it is about. I'm sure as the medical people on this team, you must be aware of this name. Cauda equina is a syndrome defined by a group of symptoms which results from compression of the terminal nerve roots, cauda equina. The important thing is the red flag sign. That's what we're talking about. The red flag sign are a danger zone. That's why you got a red traffic light to be careful and watch. So red flag sign could be because of severe low back pain. You can have a sciatica. It's often bilateral in a cauda equina, and it sometimes may be absent. Saddle anesthesia, which we normally used to think about, going back to what we used to talk about in the medicine in our undergraduates and postgraduates, that if you have a saddle anesthesia, you have a cauda equina. Very likely so, but not necessarily the case. The bladder, bowel, and the sexual dysfunction is one of the most important things which does affect people, especially the bladder symptoms. Now, a word about the anatomy. This is a picture we were taken. It's a cauda equina, like a horse tail, which spans from L1 to S5 peripheral nerves. Should not be confused with conus medullaris, which is a different syndrome. Just a word about bladder innervation. As we know, it's got both sympathetic, parasympathetic, and somatic nerves. Parasympathetic is responsible for contraction of detrusor muscles, and sympathetic for relaxation. Okay, this is a common, I'm sure you've seen day in, day out about this dermatome picture. On the right-hand side, I've given you just a line diagram of a patient who will have a saddle anesthesia, which affects S3, S4, and S5 nerve roots. Now, if you look into it, we always think cauda equina, your disc prolapse, it's not 50%, less than 50% That is about 45% of the patients have a lumbar disc herniation as a cause of chord equina. Other factors are hematoma, which is mainly for patients who operate on disc prolapse. It almost accounts to 20% post-operative because of epidural hematoma, infection because of epidural abscess. So 45%, less than 50% is because of lumbar disc herniation. Now, all in this slide, if you look into the red little words, are all about the red flags. And we should be carefully looking into all these patients. Back pain, common in a lot of other things. Mechanical back pain doesn't mean it's a chord equina. A disc prolapse doesn't mean a chord equina. But if you've got a bilateral sciatica, you should be very carefully and thinking about that it could be a cause of a chord equina. Saddle anesthesia, yes, it should be looked into as part of the symptoms. Impotency, we normally don't talk about because of being hesitant to talk about, but it is really important to be talked about when you see a patient with suspected chord equina. Sensory motor loss may or may not. Yes, you would most of the times, but not necessarily so. Neurogenic bladder function dysfunction is the most important, and we shall come across and touch in the next few slides. Bowel dysfunction is rare. To your surprise, you would think there will be bladder and bowel involvement, but bladder involvement is more as compared to bowel dysfunction. So again, the red marked letters should be read as a red flag. The clinical examination, you have to examine like any medical, like inspection and palpation. But when you come to urinary retention, you can see by palpation. Bilateral lower extremity weakness, one has to look into. The rectal and general examination is important. We always to talk about saddle anesthesia, having altered sensation around the perianal area, which only makes about 73% of the cases. The important thing is you must do it, and you must check for light touch as well as pinprick. Both, again, I would say light touch, pinprick all around, not only on the one side. Patient who will have some decreased rectal tone, again, it could be subjective. I, as a doctor, might think it's a low tone. Other doctor might think it's a normal tone, but it has to be taken into account. Bulbocavernous reflexes to be looked into patient who cannot follow your command. In this, you squeeze the penis of the clitoris with your finger in your anal canal and see for a squeeze test. If the patient got a catheter, you can have a touch test by pulling the catheter. Now, this is a chart which I would expect patients to have it in the clinic because it helps you to fight against the medical legal problem. If you've documented this chart, a patient who's come to you may not have a chord equina, but if you've not documented your findings, he goes home and after 2 days he get a chord equina and he goes and files a case. There will be nothing for you to stand on the court of law to say that it wasn't a chord equina. On the day when the patient came and you've documented with all the dermatomes specifically around the saddle anesthesia, doing a rectal examination, you would save yourself from a complication of being harassed in the court of law. So I think patient's name, date and time must be, make sure, if not time, at least the date has to be there. Now, the duration of the onset is also equally important with the medical legal because these all are looked into when the things go wrong, you see. When A&E, in accident emergency department, patients do come and they come from time to time. The same patient may be visiting casualty 3 to 4 times, maybe in 3 to 4 months. But a lot of time, because he's a repeated person coming, a lot of A&E doctors might say, it couldn't be possibly a chord equina. I don't think you should defer that. You have to make sure the patient is here for a reason. And make sure you examine him and document it again. Tandon and Sankaran has done a various study, and there quite a lot of literature goes with them regarding chord equina. They've made it 3 ways: rapid onset with previous history, without previous history of back problem, and the other person acute bladder dysfunction with a history of low back pain. These 2 are easy to diagnose because they are more rapid and they come with an increasing problem. The problem comes to the 3rd one, where there's a chronic backache and sciatica with gradually progressive chord equina, often with canal stenosis. The onset of chord equina could be within hours, and sometimes when the patient comes to you, he's already lost the battle. He's already late to come. And that's the reason when he comes, if your documentation, what stage was the chord equina, you are far, far better to avoid litigation. Now, this is in patients with confirmed quad equina syndrome. It's like a quiz, how many percentage of the patient had bilateral sciatica, how many had unilateral sciatica, how many had percentage had a saddle anesthesia, and how many patients were urinary symptoms. Well, you can phone a friend, but you don't have to. I'm your friend. The answer is here. For the bilateral sciatica, this got a 32.4% patient will have quad equina, which helps to favor your diagnosis. 58% will have unilateral. If you look into it, saddle anesthesia, which was so commonly talked about and have been taught from us as undergraduates that they have saddle anesthesia, is only 73%. You may have a patient who has come with minimal sensory motor neuropathy and with no saddle anesthesia can still have a quad equina, but this is the most important. The urinary symptoms account to 97.1%. There's been prospective analysis of 260 patients referred to different centers who are dealing with quad equina. Arrows on the right side, the red one, have to be looked into. If you look into it, 33 out of the 34 patients who had a quad equina had a problem of urinary incontinence. However, there was only 77% who had non-quad equina had urinary incontinence for various other causes. Coming to the bottom one, bladder scan. This is the most, I would again repeat and emphasize, this is the most important factor to diagnose quad equina. Post-void residual urine volume. If a patient passes water and you do a bladder scan, which is a small machine, you can have it in the ward. You don't need a radiographer to evaluate. It can be done by a nurse who's been trained as well. If a post-void residual volume is more than 200 ml, there's a very good chance the patient has got a problem with quad equina. And if it's less than 200, then probably you can sit a bit tight, but documentation is important. If you look into this, another sensitivity and specificity test, post-voidal residual volume urine of more than 200 is sensitive by 94%. However, saddle anesthesia is only 73%. A PVR, which is post-voidal residual urine of more than 200 ml, alongside with one or more symptoms of quad equina, is highly predictor and suspicious of a quad equina compression on subsequent MRI. And this is the time you should be really working hard and making very best to get this patient into the theater as soon as you can and avoid litigation. Now, I would say the only one real test, again, I'm emphasizing again and again, post-void residual urine output, having more than 2000 ml in the bladder is very important a factor with a negative predictive value of 98%. Now, this is just a picture just for you to show what quad equina looks like. Now, here we come to more of a medical legal aspect of it. Now, quad equina can be divided into 4 stages. The top 2 are big red flags. What you have to understand is the patient who comes with a severe back pain with bilateral radiculopathy has between suspected of quad equina, but you find that this patient doesn't have other symptoms of that. You could sit tight on this patient. You can have an MRI first thing in the morning, but keeping a close eye. However, quad equina syndrome, which is incomplete, a patient with having altered urinary sensation, loss of desire to void, poor urinary stream, and the need to strain to other micturate. These are urgent MRI. You can't sit. You have to get them onto the MRI scanner and rush to it. The important thing I want to make is the first 2, quad equina syndrome suspicious and quad equina syndrome incomplete, should not be landing to retention. Once you had it, when the patient was yours, you are in trouble. So you need to be acting pretty fast for the first 2, for the patient not to go into the retention. And when you go to the retention, then it's probably slightly late. However, quad equina syndrome, which is complete, here, if you have deferred MRI, you can wait. I don't think there's much of a battle to be lost from. Now, the treatment is same, whether it's 1, 2, or 3, or 4, it's surgical decompression. The timing of surgery can be debated. Various journals have shown, or various pictures people have looked into. Should it be 24 hours? Should it be 48 hours? I think you should do it as early as you can. However, we have come to know with quad equina syndrome, operated within 24 hours carries 89% of people getting back to normal bladder function. 48 hours, 79%. If you look into the moment you rush out of 48 hours from 44%, you lost from 89 to 44%. So remarkable difference. So it's important that we better go into it and get it investigated. If you can get it done within 48 hours, you are in a win-win situation and keeping yourself away from litigation, if you can. Now, quad equina syndrome with the retention, you will still go ahead and operate, but the advantage of patient getting out of the problem is not as great as before. However, quad equina syndrome who have got a problem, there's a paper from Chandigarh, if I've read somewhere in the past, they do go ahead and still operate on this patient because they feel there is a role of recovery. It may take 6 months to 1 year, but they're definitely better off after surgery. So that is, in some surgeons will go ahead and operate, some people will not. Now, the medical legal aspect of the quad equina is basically about the 4 things which has happened. Now, it could be either the failure of the doctor to examine patient for quad equina syndrome, or the doctor to recognize red flag sign. He has failed to recognize it. Failure of the nurse to recognize. Why I'm calling a nurse over here is because quad equina syndrome, 20-25% patients will have it after they have a surgery of the disc prolapse. So these patients who are being nursed next in the morning, if the nurse comes to know this patient has got a problem, she's got equal responsibility to inform the doctor. So they are equally responsible for patient to land into quad equina if they've not documented the post-op ward round, and also to failure to act promptly. If you can come over all these 4 things, I don't think there's a concern. Now, being negligent, we shouldn't be just worried about it, always thinking about that, am I being negligent? Probably not always, you know. When it goes to the court of law, what is the judge asking you? And what he expects is, has the doctor followed the reasonable protocol of examination and management as would have been expected from a doctor of the same caliber? So that would mean if any other person who was in that situation, majority would have done different, but if you're not followed those protocols, if you're not done that, then you probably will be called as negligent. And it is also not about that any other doctor is better than the doctor who was treating the patient. That is not negligent. If you have not followed the protocol as it would be expected from you, as would have been done by majority of the doctors, you could be fined negligent. Now, the medical legal aspect is that we know that with Levy et al., he's worked into, there's a 10% of the quad equina syndrome land into litigation. Why? Because 70% of the patients are between 31 to 50 years. And why so? These patients are the prime time of their working pattern. This is the time they're working hard. They've got a mortgage to pay. They've already got a kids. They have to make their career, and suddenly things have gone. So that is why the litigation goes sky high, because these patients are working people and they're responsible to look after their parents and to the society. Now, there's been various claims which has happened, and you would find that around an average in 2003 to 2007, so 117,331, almost like about 1.2 crores patients were given as a claim. Make sure there's no cost of treatment. You don't pay anything to be treated in this hospital. So an average person got 1.2 crores of compensation, but that doesn't mean that's enough. Along with that, he starts getting his wages for which he's been debarred, which he's not able to get because of not working. Along with that, he gets another 30 lakh rupees for changing his accommodation way of life. He's got a toilet upstairs to bring his toilet down. He needs a wheelchair. He needs a mobility scooter. So it is costing a lot of money. So that cost is going up over the period of time. And that's why it's important. The majority of the claims came down to delay in diagnosis and surgery. And we have to be very particular about doing a rapid imaging and rapid treatment to avoid. There's another slide that was till 2007, and you will see the cost of compensation exponentially going high and high. So out of 827 claims, only 340 were settled. So there are people who are claiming. That doesn't mean everybody is going to be successful. If you've done your duties right, you're sure you will not going to be challenged. However, if you see the cost has gone up significantly now. Now this is the NHS has costed 186 million pounds for the patient. That has gone up to almost 620,000 pounds, which is about 6.2 crores of individual plus his loss of earnings. So that's why I think we have to be careful and being very, very vigilant about the red flag sign. Now, in a nutshell, I would say the quad equina syndrome is from the lumbosacral nerve roots. Important thing, cutting short, PR sensation pain must be documented. Post-volume residual urine has to be mentioned. The quad equina syndrome, which is impending or incomplete, and residual should have a surgery. Quad equina, which is already progressed, which is type 4, question mark, you want to get an MRI early or not, that is questionable. So documentation should be clear, and we have to go for surgical decompression early. Now, along with the red flag sign, this is what we have to understand. Not only the red flag sign is important, the most important thing is listen to the patient complaint. And I'm sure this is what is the most important. And sometimes we omit that because we have to see a lot of patients. I'll tell you about a patient complaint which has happened, which I know about, is a patient who is 29 years of age. She had a daughter, she was having some pain, had seen the orthopedic doctors, and she was diagnosed of occasion having sciatica. Now, after 3 to 4 months, she rings a GP saying she's been having an increasing problem of pain, and the GP advised more strong painkillers. Now, that doesn't settle. She comes back after 3 to 4 days with increasing pain. Now the GP has given some more medication and asked to go back. That doesn't get better. Now she comes to the hospital. She comes to the hospital after 48 hours with problems of urinary retention. This is the time she is picked up having an MR. She was having a quad equina. She had a surgical intervention done, but the results were not that great. Now she goes on litigation, and the doctors are taken to the court. The judge says to the doctor, when this patient rang you for the first time, I won't charge you with any offense because the patient already had seen an orthopedic doctor. She had a sciatica, and you made the right thing of increasing the dose. But when she came next time, the patient has said that she did mention that when she passed water, when she was in the toilet, she was trying to wipe herself. She couldn't feel anything. And that the patient has said. And however, the doctor said, she didn't tell me. The Dutch said, you haven't mentioned as a negative clinical findings. So that means 9 out of 10 times, the judge will listen to the patient because the judge will think the patient had a problem. She remembers very well. You have been called to the court 3 years. You might have seen loads of patients by that time, and probably you don't stand. If you have written about the red flag sign documentation, 9 out of 10 times you would be better taken care of. And however the patient shouts, she is not going to be in a benefit. So important thing is listen to the patient complaint, give a leaflet of red flag sign to patient with chronic low back pain. Documentation is important. Results of PVR bladder scan is so important. Keep a high index of suspicion of a quad equina if you have got a patient with severe low back pain, and multidisciplinary approach. By that I mean, if you've seen a patient with low back pain, try to talk to the Department of Radiology, arrange a scan and document it. There may be possible that there may be delay in getting an MRI. There may be possible there will be delay in surgery, but you as a doctor has done your duty, you've informed these, and you will not be at risk of. So medical legal solicitors are always there to watch. It's their way of life. You will see no win, no fee. Free phone numbers available. They are going to happy to see you at home. Dedicated 24 hours helpline and website. Incentive for referring a friend and a person. Posters of advertisement in the hospital, the television are very much evident. If you look into, this is a very, very busy slide, but look at the amount of various causes of compensation the solicitors have been asked to get involved for a patient, right from the physiotherapist who, because here the physiotherapy is quite an important role. A patient with a low back pain will be seen by the physiotherapy. And if the physiotherapy fails to recognize that this patient has got an increasing back pain and doesn't refer to the appropriate department, he's going to be taken to task. Now, this is a solicitor. He's there to help, but not to help the doctors. He's there to help the people from which can make money out of it. And you'll be surprised to see this is the email which I've taken up from my wife's email, which has come as a junk email, where it says where we offer with no free services. So we are an award-winning claim management company with a track record of giving good delivery service. We are authorized and regulated by Finance Control Authority, and this is all it flows. And then you see there's another chat which has come from a patient. I recently emerged from the other side of the quota equina because of medical negligence case, which was successfully concluded, and thanks to incredible diligent work of ... I cannot thank ... and their hard work and the teamwork enough for the work in achieving me, as well as vindication that it was treated negligently, and I'm absolutely not hesitant whatsoever in recommending them to anyone who may have a misfortune to find themselves in a similar situation. Now, finally, the medical legal angle, at what stage, if at all, was the situation irretrievable of surgical decompression? So the lawyers are always difficult to question them and involve. So let's make sure the lawyers and the patients have got their own motto, and they will come back to you. But you as a doctor, if you've done your job well, if you've gone to the red flag sign, you should be better prepared. Now, we know that the properly diagnosis and investigation following the timely, skillful, and surgery or rehabilitation are essential best practice. I've written the red words that it is a tragedy that sometimes avoidable or incomplete syndromes goes into a complete while under medical supervision. This is something which has to be stopped or minimized. We'll slip the slide. Now, we know also that some of the patients die in cast means already when they come to is already 4 to 6 hours, and they have already landed into quad equina syndrome, which is already causing a stage which is going ahead where the response of the surgery will be late. But if this patient comes to that in CESR stage, if your documentation is okay, and if you mention about the red flag sign, probably you will not be taken to task. Now, the quad equina disability claims are getting more and more. And what you don't want is to go into a stage, I would say, to get from red to green, negative findings should be routinely documented. I will repeat again, negative finding. If you write it, positive finding is equally important. But when you have not mentioned the positive finding, you can't say the patient hasn't mentioned me about the positive finding. It's your duty to inform about the negative findings. So whenever you got a low back pain, increasing back pain, think of red flag sign, apply your brain and knowledge. It is only you who can make it green. Thank you.
Thank you, Dr. Sethi. Wonderful talk. And really, I think there might be so many clinicians and even orthopedic surgeons who might not be aware of this, that how much important medical legal this thing is. Thank you very much.
Yeah, I would definitely feel, I think the changing trend is it's a small equipment. If you can get a bladder scan, which can be taken into account, and make sure life will be easy, because the worry always is, and this bladder scan, I'm sure gynecologists must be using it. The urologist must be using it. If you can get a hands-on, get a bladder scan done. If it's more than 200 mils, then you have to be really, really acting onto it. If it's less than 200 mil, you can sit tight, get an MRI as early as you can. I don't think the court will take into action.
Thank you. Thank you, all the speakers. Now we have come to the end of the speaker session. We have with ourselves panelists. We have our retired judge, Dr. Paliwal, Mr. R.D. Paliwal. He is a retired district judge, former law secretary of Government of Uttarakhand, and former director, Judicial Academy, former chairman, District Consumer Forum, US Nagar, and at present he is Chairman District Police Complaint Authority Nainital. I welcome you, sir. We have with us Dr. Ashwin Setia from Max Saket. Welcome you, sir. We have with us Dr. A.S. Jaggi from Meerut. We welcome you, sir. Dr. S.S. Sodhi from Mohali, Chandigarh. Welcome you, sir. And we have with us Dr. Kedia from Haldwani. We welcome you, sir. Now, I would request the panelists to start the discussion for the benefit of the audience. And before that, I would myself start one thing from Paliwal, sir, about the Consumer Protection Act 2019. There is a controversy among the people and in IMA also, whether doctors are still in Consumer Protection Act or not, because there have been many things going on in the media. So I would like to know your views, sir.
Sir, Consumer Protection Act 2019 में जो सर्विस की डेफिनेशन दी गई सेक्शन 2(1) सब सेक्शन 42, सर्विस means service of any description which is made available to potential users and includes but not limited to, I am emphasizing these words, but not limited to, the provision of facilities in connection with banking, financing, insurance, transport, processing, supply of electrical or other energy, telecom, boarding or lodging or both, housing, construction, entertainment, amusement, or the purveying of the news or other information, but doesn't include the rendering of any service free of charge or under a contract of personal service. ऐसा ये कंट्रोवर्सी इसलिए है समझने में, ये कहा जाता है कि इतनी सर्विसेज जो अभी बोली गई हैं इनमें मेडिकल सर्विसेज नहीं है। बिल्कुल यही डेफिनेशन ओल्ड एक्ट में सेक्शन 2(1) क्लॉज ओ में सर्विसेज की थी, इसमें और क्लियर कर दिया गया है जो नया एक्ट है, बट नॉट लिमिटेड। पुराने एक्ट में भी मेडिकल सर्विसेज का स्पेसिफिक उल्लेख नहीं था। इस बारे में ऑनरेबल एपेक्स कोर्ट ने इंडियन मेडिकल एसोसिएशन वर्सेस डॉक्टर बीपी सेंथा 13 नवंबर 1995 को एक बहुत स्पेसिफिक रूलिंग दी। उसमें बहुत सारे क्वेश्चंस को आंसर किया गया है। मैं उसका केवल एक क्लॉज पढ़ूंगा। सर्विस रेंडर्ड टू ए पेशेंट बाय ए मेडिकल प्रैक्टिशनर except where the doctor renders service free of charge to every patient or under a contract of personal service by way of consultation, diagnosis and treatment, both medicinal and surgical, would fall within the ambit of service as defined in section 2 subsection 1 clause O of the Act. सुप्रीम कोर्ट का ये क्लेरिफिकेशन आने के बाद कहीं कोई विवाद की, कोई कंट्रोवर्सी की कोई गुंजाइश नहीं रह जाती, क्योंकि पुराने ओल्ड एक्ट और नए एक्ट में सर्विस की डेफिनेशन सेम है। इसलिए ऑनरेबल एपेक्स कोर्ट का जो ऑर्डर है, जो क्लेरिफिकेशन है, जो रूलिंग है, वो फाइनल है जब तक कि ऑनरेबल कोर्ट, ऑनरेबल सुप्रीम कोर्ट खुद अपनी फाइंडिंग को चेंज नहीं करती। इसमें उन्होंने 12 पॉइंट्स दिए हैं। अगर आप उन सारे पॉइंट्स को देखेंगे, पहले पॉइंट से क्लियर होता है जो मैंने अभी बताया, अगर सारे पॉइंट्स को देखेंगे तो सारी लीगल क्वेश्चन बहुत क्लियर है। इसलिए कहीं ये असावधानी हो जाए कि हम इससे कवर नहीं होते, एक निश्चिंता का भाव आ जाए, ऐसी बात नहीं। जी सर,
ओके सर। Any query about this to any other person? Unmute yourself, sir. Dr. Sodi, unmute yourself.
आवाज सर।
हाँ जी सर, गुड इवनिंग सर। पहले तो सर मेनी कांग्रेचुलेशंस टू ऑर्गेनाइजर्स फॉर ऑर्गेनाइजिंग दिस वंडरफुल सेशन। मैं जज साहब से पूछना चाहूंगा कि सर एक जस्ट मेरा पॉइंट था कि ऑनरेबल सुप्रीम कोर्ट के कहने के बावजूद जो नई गाइडलाइन आई है, सीपीए की डेफिनेशन जो आई है, उसमें गवर्नमेंट ने उसके बावजूद मेडिकल को इंक्लूड नहीं किया। क्या दैट पॉइंट कैन गो इन आवर फेवर दैट इन स्पाइट ऑफ द एपेक्स कोर्ट्स डिसीजन medical services have not been included in the new CPA Act? That means government's intention is not to include us.
नहीं सर, ये सुप्रीम कोर्ट की जो रूलिंग है, ये गाइडलाइंस नहीं है, ये उनकी रूलिंग है एंड इट इज लॉ ऑफ द लैंड। और इसके बावजूद भी अगर नए एक्ट में उन्होंने स्पेसिफिक इतनी सर्विसेज जो इंक्लूड कर रखी हैं, उसके बाद भी अगर नहीं किया है, इस डेफिनेशन के 3 पार्ट हैं। फर्स्ट एक्सप्लेनेटरी, सेकंड इंक्लूसिव पार्ट, थर्ड एक्सक्लूजन। एक्सक्लूजन में केवल और केवल इतना है, बट डजंट इंक्लूड द रेंडरिंग ऑफ एनी सर्विस फ्री ऑफ चार्ज और अंडर ए कॉन्ट्रैक्ट ऑफ पर्सनल सर्विस। अगर ये एलिमेंट नहीं है तो कोई भी सर्विस, क्योंकि ये केवल एक बट नॉट लिमिटेड टू एक शब्द इसमें लिखा हुआ है, तो इसकी वजह से जो है मेडिकल सर्विस इंक्लूड होगी।
ठीक है, थैंक यू
सर। एक चीज कहना चाहता था कि इस नए बिल को बनाते टाइम जो सेलेक्ट कमेटी थी, उसने इंटेंट में अपनी जाहिर किया था कि हम मेडिकल सर्विस को नहीं इंक्लूड करना चाहते हैं। बिल बनाने के टाइम पे इंटेंशन में जाहिर किया था, हालांकि वो चीज बाद में बिल में नहीं आ पाई। तो क्या वो चीज कोई हेल्प करेगी?
नहीं सर, जो पार्लियामेंट से जो बिल पास हुआ और उस बिल पे ऑनरेबल प्रेसिडेंट की जो एसेंट मिल गई, उसके बाद वो लॉ बन गया। लॉ बनने के बाद उसकी बैकग्राउंड क्या थी, कौन सी चीज छूट गई थी, जो छूटी हुई चीज है वो थ्रू अमेंडमेंट आ सकती है। पार्लियामेंट के पास एम्पल पावर है कि वो जो है अमेंडमेंट कर सके, परंतु जब तक अमेंडमेंट नहीं होता तो जैसा लॉ एज इट इज है वही मान्य हो।
ओके, थैंक यू।
एक बात मैं और बताऊं, डॉक्टर ऋषि भाटिया जी ने एक बात बताई थी अपने प्रेजेंटेशन में कंज्यूमर प्रोटेक्शन एक्ट पर। उन्होंने बताया था कि अब नए एक्ट में इसके जो प्रेसिडेंट हैं वो पॉलिटिकल पर्सन्स हो सकते हैं, परंतु ऐसा नहीं है। 15 जुलाई 2020 को जो रूल्स आए हैं, जिनमें कमीशंस के मेंबर्स और चेयरमैन्स की अपॉइंटमेंट की क्वालिफिकेशंस, प्रोसीजर और उनको रिमूव करने का जो प्रोसीजर है, उसमें डिस्ट्रिक्ट कमीशन के प्रेसिडेंट के लिए डिस्ट्रिक्ट जज का होना या डिस्ट्रिक्ट जज की क्वालिफिकेशन रखना ये मैंडेटरी है, जैसे पुराने एक्ट में थी। इसलिए कोई किसी भी पॉलिटिकल पर्सन्स के होने का प्रश्न नहीं होता। एक बात और नए एक्ट में आई है, वो ये आई है कि अब जो डिस्ट्रिक्ट कमीशन के या स्टेट कमीशन के जो अपॉइंटमेंट का जो प्रोसीजर होगा, जो सिलेक्शन का प्रोसीजर होगा, उस कमेटी के चेयरमैन ऑनरेबल चीफ जस्टिस ऑफ कंसर्न हाई कोर्ट वो होंगे और 2 मेंबर होंगे, एक सेक्रेटरी कंज्यूमर अफेयर्स और एक नॉमिनी ऑफ द चीफ सेक्रेटरी। ये 2 लोग मेंबर होंगे और उस कमेटी के चेयरमैन जो है सिलेक्शन कमेटी के चेयरमैन वो ऑनरेबल चीफ जस्टिस या उनके नॉमिनी जज होंगे। इसी तरह मेंबर्स के भी, इसलिए और ट्रांसपेरेंसी और कॉम्पिटेंट लोग आए, किसी प्रकार का कोई पॉलिटिकल इंटरफेरेंस न रहे, क्लीन प्रोसीजर हो, इसलिए व्यवस्था की गई है। एक बहुत अच्छी बात नए एक्ट में ये आई है कि इसमें जैसा डॉक्टर भाटिया साहब ने बताया कि मीडिएशन का है, पर मीडिएशन पुराने एक्ट में नहीं था। मीडिएशन से ये है कि कंटेस्ट करने से बच जाएंगे और कंज्यूमर डिस्प्यूट को आमने सामने बैठ के सारे मेरिट्स पार्टीज डिस्कस करेंगी मीडिएटर्स के सामने मीडिएशन सेल में, तो एक सिटिंग में भी मामला निपट सकता है और उसकी कोई अपील नहीं होगी। मीडिएशन का सबसे अच्छा फायदा यह है कि फर्दर लिटिगेशन बिल्कुल स्टॉप हो जाएगा। जो मीडिएशन सेल की रिपोर्ट है अगर वो कंज्यूमर कमीशन ने स्वीकार कर ली तो वो फाइनल हो गई। ये एक बहुत अच्छी बात है।
यस डॉक्टर अश्विनी।
मैं एक प्रश्न करना चाहता हूँ आपसे।
जी बताइए।
आपने बताया कि जो सिलेक्शन जो प्रेसिडेंट की होनी चाहिए वो जज की क्वालिफिकेशन होनी चाहिए, लेकिन जो उसकी डेफिनेशन में आया है और इक्विवेलेंट क्वालिफिकेशन, इक्वल आइदर ही हैज बीन अ डिस्ट्रिक्ट जज और इक्विवेलेंट क्वालिफिकेशन, वो इक्विवेलेंट क्वालिफिकेशन कहीं डिफाइन नहीं की गई है।
हाँ, इक्विवेलेंट क्वालिफिकेशन का मतलब ये होता है सर कि जो डिस्ट्रिक्ट जज हो सकता है, कौन डिस्ट्रिक्ट जज हो सकता है कि जो ऑलरेडी पहले से जज हो, एडिशनल डिस्ट्रिक्ट जज हो, वही डिस्ट्रिक्ट जज हो सकता है। कोई भी अदर फील्ड का आदमी डिस्ट्रिक्ट जज नहीं हो सकता है। जैसे मैं आपको एक उदाहरण बताऊं कि चीफ मेडिकल ऑफिसर है, चीफ मेडिकल ऑफिसर होने के लिए कौन एलिजिबल है? जो ऑलरेडी पहले से डॉक्टर, उन्हीं में से सीनियर आदमी वो चीफ मेडिकल ऑफिसर होते हैं। ये नहीं कि कोई जज चीफ मेडिकल ऑफिसर हो जाए। तो ये इसका इंटरप्रिटेशन ये है सर।
जी धन्यवाद।
आई थिंक दिस इज बहुत इंपॉर्टेंट पॉइंट है जो मीडिएशन वाला है। ये बड़ा अच्छा पॉइंट है क्योंकि सर अक्सर अल्टीमेटली मीडिएशन ही होता है। तो आउट ऑफ कोर्ट सेटलमेंट जो था दैट वाज डेंजरस कि somebody can still go to court after taking the money। अब मीडिएशन होने से ये फायदा हो जाएगा कि इट विल बिकम ए लीगल प्रोसेस। आई थिंक दिस इज ए वेरी वेरी बिग एडवांटेज।
पहले आउट ऑफ कोर्ट होता था सेटलमेंट।
हाँ जी।
अब जब मीडिएशन सेल के सामने होगा तो सारी बातें सामने हो जाएंगी। क्या कंप्लेंट फर्जी है, क्या कंप्लेंट में डिवॉइड ऑफ मेरिट्स है, और कितनी नेग्लिजेंस है या नहीं है, वो आमने सामने बैठ के बिल्कुल तय होगा सर।
हाँ सर, ये बढ़िया हो गया, ये अच्छा हो गया है।
बहुत अच्छा।
एक नेगेटिव पॉइंट है कि देयर इज नो पेनल्टी फॉर फ्रिवलस कंप्लेंट्स। इसका मतलब है एनीबॉडी कैन फाइल कंप्लेंट एनी टाइम एंड कीप ऑन हैरेसिंग डॉक्टर्स।
हाँ, फ्रिवलस कंप्लेंट का पहले 10,000 फाइन था, अब वो फाइन नहीं है, बट फ्रिवलस कंप्लेंट डिसमिस होगी। और वो उसके बाद अगर कोई भी सर्विस प्रोवाइडर इसके बाद कोई मैलिशियस प्रोसीडिंग का कोई अलग से सूट ला सकता है और ये बात कह सकते हैं कि ये फ्रिवलस कंप्लेंट थी। इस फ्रिवलस कंप्लेंट को डिस्ट्रिक्ट कमीशन या स्टेट कमीशन और नेशनल कमीशन एज द केस में भी उन्होंने इसको तय किया है कि ये फ्रिवलस कंप्लेंट।
ओके, लाइक फॉर एग्जांपल
यस
यस डॉक्टर ऋषि।
क्या मेडिएशन सेल में डॉक्टर्स को रखने का भी प्रावधान होगा?
मेडिएशन सेल में जो मीडिएशन की प्रक्रिया को जानते हो, ट्रेंड मीडिएटर जो हो, शब्द आया है ट्रेंड मीडिएटर, जिन्होंने मीडिएशन की ट्रेनिंग ले रखी है, तो कहीं कोई बाधा नहीं है मीडिएशन सेल में। अगर वो उन्होंने मीडिएशन की ट्रेनिंग ले रखी है, बिल्कुल रखा जा सकता है। उसके अलग से रूल्स अभी नोटिफाई होने हैं, अभी उसके रूल्स नोटिफाई नहीं हुए हैं कि उनकी ट्रेनिंग कहाँ होगी, ये अभी नहीं है। पर कोई उसमें कहीं ये एक्सक्लूड नहीं किया गया है कि मेडिकल प्रोफेशंस के लोग नहीं होंगे, एक्ट में कहीं एक्सक्लूड नहीं किया गया, हो सकते हैं बिल्कुल।
ठीक है सर। Now we can carry the discussion away from the CPA and for other things, sir. डॉक्टर नागपाल से कोई क्वेश्चंस अगर पूछने हो, उनका बड़ा इम्पोर्टेंट टॉपिक था
May I leave, sir?
मॉब वायलेंस का।
May I leave?
सर अगर आपको जल्दी है तो बिल्कुल, लेकिन अगर आप एंजॉय करेंगे तो हमें अच्छा लगेगा।
अच्छा, थैंक यू सर।
Dr.
यस
Nagpal, Dr. Nagpal, very useful presentation as usual.
जज साहब से
अब for डॉक्टर साहब ऐसा है कि it is unfortunate कि पहले knowledge and practice का system था, अब it is system of maintaining relations with the media and the police. Unfortunate for the medical field. But मेरा question ये है कि since sympathies always lie with the patient, should doctors and hospitals wait for social justice or should have arrangements for immediate retaliation in case of violence? क्योंकि बाद में तो mediation ही होना है, बाद में तो justice मिलना है, पता नहीं क्या होना है, क्या नहीं होना है. So should there be bouncers in all hospitals for immediate retaliation? अब बाद में तो फिर जो होता है वो होता रहेगा.
Dr. Sodhi, a lot of people have been recommending use of bouncers in hospitals. I personally do not agree with this. The reason is very, very clear that at least academically, there was a study which was done in China where they increased the security in hospitals and found that the incidents of violence actually increased with increasing security. That in itself used to induce people to become violent. So that was not found to be helpful. And bouncers, the mere presence of medical staff along with the doctors when the counseling session is going on is more important than a display of force. This display of force does not work in medical setting, and in case any injury occurs to a patient attendant or a patient party, especially by the bouncer, the society today has already made up its mind that doctors are crooks, and this will add fuel to the fire. So I am not very convinced. Yes, you should have security, but excessive show of force or excessive show of these bouncers is probably not a very wise thing. Yes, what you said later, a settlement is to be done. I am not particularly in favor of a settlement also, because once you do the settlement, you are condoning the act of violence which the persons have perpetrated. Now you say that the violence which was perpetrated was justified because the relative of the patient expired, because the relative of the people who perpetrated the violence expired. So you think the violence was justified, hence it should be condoned. This is the thinking of the police, this is the thinking in the judiciary, this is the thinking in the press, this is the thinking in society. I have always argued on one thing. If justifiable crime is not a crime, then why did we prosecute Indira Gandhi's killers? They had a justification in their mind. Why do we prosecute anybody who stabbed somebody because that somebody was flirting with his wife? He had a justification in his mind. A crime is a crime which needs to be punished. So I am totally against the culture of settlement, because violence has occurred and a case of criminal negligence has been filed. These are two separate issues. The two separate issues have to be dealt with separately. If it is a criminal negligence, it will be punished as a criminal negligence. But the violence is a crime, and not pursuing the incident of violence, you have missed that slide of mine, this broken window hypothesis. What does broken window hypothesis say? किसी लड़के ने आपके घर पे पत्थर मारा, शीशा तोड़ दिया. It was a minor crime. आपने उसको कंडोन कर दिया. अगली बार उसने दरवाजा तोड़ के आपके घर से फ्रिज भी उठा के ले जाना है. This broken window hypothesis says very clearly there should be no tolerance even for minor crime. Unless and until in medical profession and in the issue of violence against doctors, even minor incidents need to be prosecuted. A deterrent needs to be created.
I agree with you. Sir, I agree with you. मेरा सिर्फ मेरा बोलने का मतलब ये था, number one, with the bouncers around, the incidence of violence may increase, but the amount of grievous injuries to doctors will definitely decrease. Number one. Number two, when I said settlement, I didn't mean that you go for it. But what we have seen is, when we file an FIR, there's a counter FIR. Then, a lot of politicians, everybody comes in the picture. कि जो हो गया वो बेचारे अपसेट थे, बेचारे ये थे. तो मेरा मतलब था कि FIR का हिसाब किताब तो बाद में होता रहेगा. एक ऑन द स्पॉट अगर हिसाब किताब कर दीजिए तो उसमें थोड़ा सा ये हो जाता है कि पब्लिक नोज कि अगर हम 2 मारेंगे तो एक हमें पड़ेगी भी कम से कम. अभी ये हो रहा है कि 2 मारेंगे, बाउंसर है नहीं, जितना मर्जी डॉक्टर को पीट लो. When you get tired of beating a doctor, go and file an FIR against him. And then ultimately what has happened? How many have been prosecuted till now? How many have been jailed? How many have been convicted? So we are relying on justice on the society. How much of it have we really got till date as per data available? Is there any study in India available?
We had I asked Punjab government, Haryana government, the police of Punjab and Haryana both, in 5 years, how many cases were filed under Prevention of Violence Act. This RTI was filed around 2016, and the data and the act was available and notified for Haryana and Punjab in 2008 and 2009. And under RTI, the information we got was there was only one case which was pending in court. There was no other FIR which was lodged. All cases had been settled. How these FIRs got withdrawn or why FIRs were not lodged, we don't know. But this was the information under RTI, and I have always said that these Prevention of Violence Acts are paper tigers. We are not in a position to use them, but fault does not lie only with the government or the law and order departments. Problem also lies with us, because when a doctor faces violence, he approaches Medicolegal Action Group, he approaches IMA, and Dr. Sirohi and others will go to the police station or go to the place with the doctor concerned. But 5 days later, when I ring up the doctor and find out उस case का क्या हुआ, the doctor says कि जी हम pursue नहीं करना चाहते, because he has been convinced कि a compromise is the best solution and you get out of this. So this is where the fault lies. As doctors, we are covered to pursue our legal right to prosecute individuals who have committed a crime. If I have committed a crime, I am not going to be spared. My prosecution will anyway occur. The point is, these are two separate issues and they should not be linked. And no amount of justification justifies a criminal offense.
You have nailed the problem, sir. And I think one should, we can do that, we should write this law at prominent places of our hospitals. Usse, the people will read it again and again and they will be somewhat, they will not dare to do the things.
No, absolutely, this is a good idea. Many hospitals are following this also, and it is written in different languages. And Maharashtra, in fact, they have designed a poster in which from the police side, this message is posted in hospitals. So carries more weight.
Okay, sir. So we will, in our state also, we will go to all the branches, and this should be written in bold letters at the prominent places.
You can write to the Director General Police of the state. Get
that
him,
we have done. That we have done.
Get him to write a letter informing all the police personnel and post that letter along with this notice on the hospital premises.
Okay, sir. Thank you. That is good idea. Yes, Dr. Anurag.
सर मैं ऑनरेबल जज साहब से जरा ये पूछना चाहता था कि अगर जो जैसे डॉक्टर नागपाल ने बताया था कि कोई वायलेंस की इंसिडेंस होती है और उसके बाद कोई इन दोनों में एक सेटलमेंट हो जाता है और इन द डॉक्टर पेज सम अमाउंट टू द पेशेंट, तो नंबर 1 क्या उसकी कोई भी इंपॉर्टेंस नहीं है? उसने पे किया है, सिर्फ डॉक्टरी नेग्लिजेंस से ये सेटलमेंट भी माना जा सकता है, नंबर 1। या कुछ लोगों ने ये सजेस्ट किया था कि भाई ये जो सेटलमेंट हुआ है इसको आप जो रजिस्ट्रार ऑफिस है तहसील वगैरह में वहां जाके आप इसको नोटरी करा लीजिए और इनके साइन ले लीजिए, तो उससे इसकी क्या कोई डज इट एज्यूम एनी लीगल इंपॉर्टेंस? और उसके बाद भी वो कंज्यूमर कोर्ट्स में या सिविल कोर्ट्स में कहीं भी जा सकता? मतलब we have been told that he can go to the courts, civil courts, consumer courts in civil cases even after this settlement.
पालीवाल सर आपके लिए है
क्या उसकी सेटलमेंट की
अगर
कोई भी इम्पोर्टेंस है या नहीं है?
हाँ बिल्कुल, अगर उनका कंप्रोमाइज हो गया है, कोई सेटलमेंट हो गया है, फिर वो अगर कंज्यूमर कमीशन में जाते हैं, कंज्यूमर कमीशन में जाते हैं अपना क्लेम लेके, तो वो जो पहला जो सेटलमेंट होता है सर, वो बार करेगा कंप्लेंट को, फ्रेश कंप्लेंट को बार करेगा।
What do you mean by
क्योंकि हाँ, वहां पर जो है बार करेगा और ये बात कही जाएगी कि ये इनकी जो कंप्लेंट है, इनका जो इनके रिड्रेसल्स हैं, जो इनके ग्रीवांसेज हैं, वो समाप्त हो चुकी हैं कंप्रोमाइज के साथ ही, बशर्ते कंप्रोमाइज प्रॉपरली ड्राफ्टेड हो, दोनों पार्टीज के सिग्नेचर हों, विटनेसेज हों, वो ये ना कह सके कि कंप्रोमाइज जो है वो फोर्स्ड है, ऐसा कोई ना कह सके। और एक बात मैं और बताऊं सर, मेरा जो एक्सपीरियंस रहा है, मैं डिस्ट्रिक्ट कंज्यूमर फोरम का चेयरमैन रहा, मेरे सामने केवल मेडिकल प्रोफेशन से संबंधित केवल 2 कंप्लेंट आई सर, केवल 2 कंप्लेंट। एक कंप्लेंट आई जिसमें ये बताया गया था कि 6 महीने का वूम में बेबी था, दो थे, फोइटस 2 थे, परंतु रेडियोलॉजिस्ट ने 1 बताया। अगर वो सही रिपोर्ट देते, अगर 2 फोइटस थे तो हम प्रॉपर केयर कर लेते।
ये काशीपुर के आसपास का
ये सर रुद्रपुर का है। दूसरा एक कंप्लेंट आई थी काशीपुर की, जिसमें हॉस्पिटल कॉम्प्लेक्स के अंदर जो मेडिकल स्टोर होता है, वहां से एक्सपायरी डेट का एक सिरप सेल हुआ था। तो उन्होंने कहा एक्सपायरी डेट का सिरप सेल होने से हमारी तबीयत खराब हुई। मैं आज भी इस बात को कहता हूं सर, बिल्कुल फर्जी कंप्लेंट कोई नहीं करता। आज भी इतनी रेस्पेक्ट है मेडिकल प्रोफेशन के प्रति, वो बिल्कुल भगवान मानते हैं सर। फर्जी मतलब एक एप्रीहेंशन हो सकता है कि कंप्लेंट फर्जी हो, परंतु उधम सिंह नगर जिले में, जहां रुद्रपुर में इतने नर्सिंग होम हैं, काशीपुर में इतने हैं, आपके खटीमा में हैं, जसपुर में हैं, केवल 2 कंप्लेंट, और इन कंप्लेंट को एक कोई भी आदमी कहेगा हाँ ये वास्तव में जायज कंप्लेंट थी, जायज कंप्लेंट थी। इसलिए सर कोई पैनिक में आने की बिल्कुल आवश्यकता नहीं है। जी सर बताएं।
सर मैं एक चीज बताना चाहूंगा,
सेटलमेंट नहीं करते, लेकिन सर वो सेटलमेंट जो करा जाता है वो ज्यादातर ये वायलेंस जो उसे डिसिपेट करने के लिए भी करा जाता है, कभी किस तरह से लड़ाई झगड़ा खत्म हो और इसे मामले को सुलझाया जाए, इन्हें कुछ पैसे दे दिए जाए। ये मोस्टली
वही तो बात हो रही है।
हाँ वही इसी की बात हो रही है सर। अगर सेटलमेंट हो जाता है और प्रॉपरली एग्जीक्यूट किया जाता है सर, एग्जीक्यूट करते समय सावधानी हो, ऐसा नहीं हो कि कंप्लेनेंट पक्ष से, एग्रीव्ड पक्ष से कोई भी कर ले सिग्नेचर, या उनके पूरे नाम उनके आइडेंटिटी, विटनेसेस जिन्होंने उनको आइडेंटिफाई किया हो, और इधर हॉस्पिटल मैनेजमेंट की तरफ से बहुत रिस्पॉन्सिबल पर्सन वो उसको करें एक तरफ से। तो दोनों पार्टीज के अगर होंगे, चाहे वो कोई भी कॉज ऑफ एक्शन हो सर, चाहे वो मॉब वायलेंस को रोकने के लिए हो या उनके किसी क्लेम के सेटलमेंट के बारे में हो, तो उस बारे में वो प्रिवेल करेगा सर, क्योंकि वो एक कॉन्ट्रैक्ट है सर, एक कॉन्ट्रैक्ट हो चुका लीगली बिल्कुल। और जब एक कॉन्ट्रैक्ट लीगली हो चुका तो दोनों पार्टी उस कॉन्ट्रैक्ट से बिल्कुल बंधे हुए हैं। हाँ, उसे जो है अगेंस्ट लॉ नहीं हो सकता सर, अगेंस्ट लॉ नहीं होना चाहिए।
नोटरी भी कराया जाना चाहिए, रजिस्टर्ड कराया जाना चाहिए।
हाँ अगर करा दे बेहतर है सर, कल को ये नहीं कह सकते कि हमने तो ये नहीं किया था। नोटरी के कराने से ये होगा, उसको लीगल फोर्स और मिल लेगा सर,
तो अदालत में मानने होगा, उसके बाद
मानने को बाध्य है सर।
उसके बाद कंज्यूमर कोर्ट में नहीं जा सकता फिर वो।
यस डॉक्टर अश्विनी
सर, अगर कोई चले भी गया तो वहाँ WS दिया जाएगा। कंज्यूमर कोर्ट में सर्विस प्रोवाइडर अपना जो WS देंगे, रिटर्न स्टेटमेंट देंगे, उसमें इस बात को लगाएंगे, उसमें इस बात को मेंशन करेंगे, और उसके साथ वो जो कॉन्ट्रैक्ट, जो एग्रीमेंट हुआ है, जो सेटलमेंट हुआ है, उसकी कॉपी लगाएंगे उसके बाद उसमें कोई मेरिट ही नहीं रही सर। बेईमानी तो किसी के मन में आ सकती है कि इधर एग्रीमेंट भी कर लें, उसके बाद कंज्यूमर कमीशन भी चले जाएं।
यस डॉक्टर अश्विनी पूछे।
सर
सस्टेनेबल नहीं है सर।
मैं आपके एक मेरा छोटा सा कमेंट है
जी।
मैंने एक स्टडी करी थी जब मैं मेडिकल डिप्लोमा मेडिकल लॉ और एथिक्स में कर रहा था नेशनल लॉ स्कूल से, जिसके तहत हमने ये पाया कि केसेस जो हैं वो डिस्ट्रिक्ट कमीशन से हटके स्टेट और नेशनल कमीशन में जा रहे हैं, क्योंकि लगातार जो क्लेम अमाउंट है वो बढ़ता चला जा रहा है और डिस्ट्रिक्ट कमीशन की जुरिस्डिक्शन जो थी वो कम की क्लेम अमाउंट की थी। संभवतः वो एक कारण हो सकता है कि डिस्ट्रिक्ट कमीशन में आपके पास केवल 2 केसेस आए हों आपके कार्यकाल के तहत, क्योंकि उसके बाद जब से शाह का केस हुआ है 11.5 करोड़ का, तब से तो हर एक ने करोड़ों में ही क्लेम मानना शुरू कर दिया। और इस वजह से वो स्टेट कमीशन से भी हमने ये पाया कि दिल्ली मेडिकल काउंसिल और दिल्ली स्टेट कमीशन में केसेस घट रहे हैं साल दर साल और नेशनल कमीशन में बढ़ रहे थे। और पॉसिबल ये रीजन भी हो सकता है, मुझे नहीं मालूम, पर पॉसिबल ये रीजन भी हो सकता है कि जो नया कंज्यूमर प्रोटेक्शन एक्ट 2019 आया है उसमें डिस्ट्रिक्ट कमीशन में ज्यादा केसेस आएंगे बनिस्बत की स्टेट और नेशनल में।
बिल्कुल सही कह रहे हैं सर। अब जुरिडिक्शन जो है पिक्यूनियरी जुरिडिक्शन डिस्ट्रिक्ट कमीशन का 5 करोड़ रुपया, इससे 5 करोड़ रुपया होने से अधिकतर केसेस कवर हो जाएंगे। आपकी बात बिल्कुल सही है, पहले केवल 10 लाख रुपए का जुरिडिक्शन था, इसलिए जो है केसेस कम हो सकते हैं। पर उससे एक जो डिस्ट्रिक्ट कमीशन का जो पिक्यूनियरी जुरिडिक्शन बढ़ाया है, एक फायदा ये भी है कि पहले स्टेट कमीशन अधिकतर राज्यों की राजधानियों में और राजधानी में जाके पैरवी करना, राजधानी में जाके अच्छे एडवोकेट को ढूंढना, वहां जाके अपना जो है WS तैयार कराना, वो दूरी का एक सुविधा हो गई कि हमको डिस्ट्रिक्ट लेवल पे ही 5 करोड़ तक को डिफेंड करना है, एक सुविधा हो गई है। अधिकतर केसेस हमारे इधर ही आ रहे हैं। बट फिर भी मैं बताऊं आपको कि जितना मैंने लॉ पढ़ा है, कंज्यूमर लॉ जो डिसाइड हुए हैं, उसमें मैंने देखा कंपैरेटिवली कम है सर केसेस।
यस डॉक्टर नागपाल।
2-3 पॉइंट्स। शांता एंड अदर्स की जजमेंट के बाद 1400% increase in cases filed in consumer courts have occurred till now. जो ये डाटा निकाला जा रहा है, आप एक उत्तराखंड में क्या हो रहा है, जब हम डाटा निकालते हैं, प्रॉब्लम ये है कि हमें कई स्टेट्स का तो डाटा उसमें मिलता ही नहीं है और डिस्ट्रिक्ट फोरम्स का तो मिलता ही नहीं है, क्योंकि वहां स्टेट कमीशन या नेशनल कमीशन, आप लॉ फाइंडर उठा लीजिए, आप इंडियन कानून उठा लीजिए, आप नेशनल कंज्यूमर डिस्प्यूट रिड्यूसल कमीशन की वेबसाइट पे चले जाइए, तो इट इज ओनली स्टेट नेशनल जो उसमें आते हैं, डिस्ट्रिक्ट वाले तो आते ही नहीं, रिपोर्टेड ही नहीं होते, तो पता भी नहीं चलते। दूसरी बात, एक बात जो हो रही थी बार बार हमारी सेटलमेंट की, आप आ गए हैं कोर्ट सुपरवाइज्ड सेटलमेंट पे। कोर्ट सुपरवाइज्ड सेटलमेंट यस, बट कोर्ट अनसुपरवाइज्ड सेटलमेंट इट इज अ बिग नो। बट प्लीज एक बात और समझ लीजिए, 2014 का सुप्रीम कोर्ट का डिसीजन है कि आपने सेटलमेंट कर ली, इट डज नॉट मीन एन FIR लॉज्ड अगेंस्ट यू विल बी क्वॉश्ड। आप अगर आपस में सेटल करते हो किसी चीज को पैसे दे ले करके और आपके अगेंस्ट एक FIR लॉज हुई है, क्रिमिनल केस लॉज हुआ है, वो क्रिमिनल केस ऑटोमेटिकली इट डजंट बिकम विड्रॉन, बिकॉज वो जो है, आई मीन इफ यू वांट आई कैन गिव यू द जजमेंट, this Gold Quest India Private Limited versus State of Tamil Nadu. This is the judgment from Supreme Court 2014 and be very clear कि आपने सेटलमेंट कर ली, पुलिस तो चाहेगी सेटलमेंट, क्योंकि सेटलमेंट के दौरान उसे पैसे दोनों तरफ से मिलते हैं। वो केवल डॉक्टर तो दे ही रहा है, वो जब पुलिस सेटलमेंट कराती है तो वो दोनों तरफ से। और ये प्रैक्टिकल एक्सपीरियंस है मेरा, कम से कम 2-3 स्टेट्स में मैं कई बारी इंसिडेंट्स के बाद मैं जा चुका हूं और हर बार यही बात होती है कि जब क्रॉस FIR है, बिठा करके डॉक्टर साहब सेटल कर लो, उसका पेशेंट मर गया, आई मीन ऑल दीज काइंड ऑफ थिंग्स। बट द सेटलमेंट, this thing is very very clear. You want to settle, please settle, but settle in a court supervised manner. Out of court settlement जो पुलिस स्टेशन में बैठ के आप कर रहे हैं, या आप जो कोई दो बंदे आपने सोसाइटी के बुला लिए और उनके साथ बैठ के कर लिया, do not think this absolves you either of the criminal negligence or it stops the patient from taking that piece of paper to court. We have 3 or 4 cases. If you want, I can give you references for them also, where a settlement has been done and a consumer case has been filed. Later, taking that settlement and giving it to the court, saying that this is the proof that negligence was there. That is why the doctor give us this money to hush up the matter. So this settlement issue, I am court supervised, yes. Court unsupervised and not in agreement कि a notary is doing the same job as a judicial magistrate. So that I think will be acceptable.
बिल्कुल आपने सही कहा सर। मैं आपको बताता हूँ, सेटलमेंट या तो सिविल कोर्ट में जाएगा, सिविल कोर्ट, या कंज्यूमर कमीशन में जाएगा। अगर वहां जाता है वो सिविल नेचर का है, सिविल नेचर में लॉ ऑफ कॉन्ट्रैक्ट प्रिवेल करेगा। जहां तक क्रिमिनल लॉ की बात है, क्रिमिनल लॉ में सेटलमेंट की 2 स्टेज हैं, या तो इन्वेस्टिगेशन की स्टेज पे है या आफ्टर फाइलिंग ऑफ चार्जशीट है। अगर आफ्टर फाइलिंग ऑफ चार्जशीट है तो कोर्ट के अंदर जो सेटलमेंट होगा वही मान्य होगा। अगर ड्यूरिंग इन्वेस्टिगेशन एफआईआर हो गई है, इन्वेस्टिगेशन चल रहा है, पुलिस थाने में बातचीत चल रही है, अगर वहां कोई सेटलमेंट होता है, उस सेटलमेंट को उसका जो समाधान निकलता है, समाधान ये निकलता है कि तो आईओ जो होता है, इन्वेस्टिगेटिंग ऑफिसर जो होता है, वो जब बयान लेता है, उनके स्टेटमेंट लेता है, विक्टिम पार्टी ये जो स्टेटमेंट लेता है, उसमें वो बात कहते हैं कि हमारा सेटलमेंट हो गया है, अब हमें कुछ नहीं कहना। उसके आधार पर इन्वेस्टिगेटिंग ऑफिसर उसमें फाइनल रिपोर्ट लगाता है। जब फाइनल रिपोर्ट लगाता है तो उस फाइनल रिपोर्ट को अक्सर कोर्ट स्वीकार करती है और फिर कोई समन आने का, कोई प्रोसिक्यूशन होने का प्रश्न ही पैदा नहीं होता। अगर चार्जशीट फाइल हो गई कोर्ट में, उसके बाद अगर कोई सेटलमेंट होता है तो वो कोर्ट के अंदर ही करना चाहिए। कोर्ट के अंदर जो सेटलमेंट होता है उसमें क्या होता है कि कंपाउंडिंग होती है, कंपाउंडिंग ऑफ ऑफेंस। उसमें क्या होता है कि वो कोर्ट के अंदर वो दोनों पार्टी कहती हैं कि हमारा सेटलमेंट हो रहा है, कोर्ट कहती है ठीक है आप सेटलमेंट कर लीजिए। उसके बाद अगर उन दोनों पार्टीज का सेटलमेंट होता है तो वो कहता है कि ठीक है मैं इसको जो है समन कर रहा हूँ, इस केस को कंपाउंड कर रहा हूँ, जो विक्टिम पक्ष होता है, तो उस आधार पर कोर्ट फिर ऑर्डर कर देती है कंपाउंडिंग का, सेक्शन 321 ऑफ सीआरपीसी में। तो जब चार्जशीट फाइल होने के बाद कोर्ट के अंदर किया गया सेटलमेंट मान्य है। चार्जशीट फाइल होने से पहले इन्वेस्टिगेशन के दौरान आईओ के समक्ष अगर कोई सेटलमेंट होता है तो आईओ उस आधार पर चार्जशीट लगा देते हैं। और जहां तक सिविल लॉ की बात है, चाहे वो सिविल कोर्ट में कोई डैमेजेस के लिए जाए लॉ ऑफ टॉर्ट के अंतर्गत, चाहे वो कंज्यूमर कमीशन में जाए, वहां वो सेटलमेंट की बात प्रिवेल करेगी। सर ये लीगल पोजीशन।
नागपाल सर, इससे समाधान हो गया सर?
जी
जज साहब के बोलने से समाधान हुआ?
सर ये आर्गुमेंट बहुत सारी रात चलती रहेगी। I am not going to be easily convinced on this issue. I have been involved in negotiating settlements between the doctors and patient parties. ये एरिया में, इस रीजन में ये मैं बहुत ज्यादा फेस कर चुका हूँ और हर बारी मुझे बुलाया जाता है, हर बारी कुछ ना कुछ। The point remains and जो judgments इस चीज पे हैं, references मैं दे सकता हूँ। ये चीज सेटलमेंट जो इस तरह से की जाती है automatically does not finish a criminal matter. It is not automatic. It will depend on the facts and circumstances of the case, but it is not automatic. Number one.
बिल्कुल क्लियर है। I do agree.
जो सेटलमेंट I will much better prefer, अब तो आर्बिट्रेशन वैसे था, तो आर्बिट्रेशन लॉ पहले भी, पुराना भी एक आर्बिट्रेशन एक्ट था
1940 का।
नहीं सर, उसके बाद
अब तो 96 वाला है आर्बिट्रेशन लॉ,
96 वाला। सो आर्बिट्रेशन एक्ट हम पहले भी कहते होते थे कि भाई आर्बिट्रेशन एक्ट के अंडर हम कॉन्ट्रैक्ट करें और उसके हिसाब से ट्रीटमेंट करें, बट दैट टाइम आई यूज्ड टू बी कंसिडर्ड कि ये पता नहीं कहाँ की बातें कर रहा है. But today I am happy CPA 2019 has brought this thing. Problem only is doctors कोर्ट पहुंचना नहीं चाहते. वो पहले ही कुछ पैसे दे करके मैटर को रफा दफा करना चाहते हैं. ये चीज जो है, दिस इज वन ऑफ द वर्स्ट पॉसिबल थिंग्स. वो मार भी खा लेते हैं, इंजर भी हो जाते हैं, पैसे भी देते हैं, पेशेंट पार्टी को भी देते हैं, पुलिस को भी देते हैं, और परस्यू भी नहीं करते मैटर जो उनके अगेंस्ट वायलेंस हुई, उस चीज को मैटर को परस्यू भी नहीं करते. गलती है बंदे की, आप उसको प्रोसिक्यूट करिए. आई एम 100% इन एग्रीमेंट. अगर मैंने किसी को चाकू ले जाके मारा है, फाइन, आई एम लायबल फॉर द पनिशमेंट व्हिच इज गिवन टू मी. बट ये चीज कि दूसरा पार्टी मेरे को मारे और आप ये कहो कि वो जस्टिफाइड था, दिस इज समथिंग. और एज डॉक्टर्स हम लोग मैटर को परस्यू भी नहीं करते कि नहीं जी वो मेरी वाइफ कहती है जी क्या करना, झगड़ों में क्यों पड़ना, वापस चल, मत फाइल करो.
ये बात बिल्कुल सही है, वाइफ को तो सुनना पड़ेगा उसको.
नहीं, बिल्कुल सही कह रहे हैं आप. अगर कोई वायलेंस हुई है ऑनरेबल डॉक्टर्स के साथ, तो बिल्कुल उनको एग्जेम्पलरी पनिशमेंट दिलवाना चाहिए और केस को बिल्कुल परस्यू करना चाहिए. अगर किसी शहर में ऐसे 2-3 लोग पनिश हो गए ना, तो बिल्कुल कोई नहीं करेगा. बिल्कुल सही कह रहे हैं आप.
And I think that this forum should give this message to all our audience that they should come out with this. थोड़ा हिम्मत करें और ये काम करें.
बिल्कुल सही कह रहे हैं. लॉर्ड रेविस के साथ कोई समझौता नहीं होना चाहिए. बिल्कुल सही कह रहे हैं.
पॉलीवल सर, आपसे एक मेरा छोटा सा सवाल है जो मेरे दिमाग में कीड़ा बहुत देर से घुसा हुआ है.
बताएं.
जो इंडियन मेडिकल एसोसिएशन वर्सेस वीपी शांता एंड अदर्स की जजमेंट थी, दैट इंटरप्रेटेड कंज्यूमर प्रोटेक्शन एक्ट 1986 as it existed. Today, Consumer Protection Act 1986 stands repealed. Does the interpretation of Supreme Court of a repealed act hold good for a new act which has come in now? There were 48 sections there. Now there are 117 odd sections in this act. It is a different act. Does the interpretation of a 1986 act hold ground in this 2019, or do we have a legal basis to ask the Supreme Court to re-look into the matter?
सर ऐसा है, बिल्कुल आपने सही कहा, ये डाउट एक हो सकता है, पर जो 95 का केस था सर, उस केस में सुप्रीम कोर्ट ने केवल और केवल किस चीज को एग्जामिन किया, क्या मेडिकल सर्विसेज जो एक्ट में सेक्शन 210 में जो सर्विस की डेफिनेशन दी गई है, क्या उससे कवर होते हैं कि नहीं होते.
बिल्कुल ठीक.
वही डेफिनेशन अब भी है, बिल्कुल, बल्कि उसमें 2 शब्द बढ़े हैं, कोई शब्द हटा नहीं है पुरानी डेफिनेशन. अगर आप उन दोनों डेफिनेशंस को, आप तो लोग बहुत अच्छी तरह जानते हैं, अगर आप उन दोनों डेफिनेशंस का एक एक शब्द देखेंगे तो उसमें तो कुछ गुंजाइश एक इंटरप्रिटेशन की हो सकती थी, बट इसमें इन्होंने कहा बट नॉट लिमिटेड टू. तो इतना बड़ा एरिया इन्होंने कर दिया अब नए एक्ट में डेफिनेशन में. तो डेफिनेशन तो सेम है सर. जब सेम डेफिनेशन है, बल्कि और बड़ी डेफिनेशन हो गई है उसको समझने के लिए, बट नॉट लिमिटेड टू उन्होंने जहां कह दिया इन सर्विसेज.
आई अंडरस्टैंड दैट. मैं तो एक लिमिटेड क्वेश्चन पूछ रहा हूं
तो सर
कि सुप्रीम कोर्ट ने एक एक्ट जो अब रिपील हो गया, दूसरा
रिपील, हाँ बिल्कुल सही कह रहे हैं, बट जो सेक्शन की जो लैंग्वेज है ना सर, वो पैरामेटीरिया है, एक ही लैंग्वेज है. अगर कभी मैटर सुप्रीम कोर्ट के सामने गया, अगर कभी कोई मैटर सुप्रीम कोर्ट के सामने गया, तो सुप्रीम कोर्ट के सामने जो कंप्लेनेंट होगा उसका आर्गुमेंट यही होगा कि एक बार सुप्रीम कोर्ट इस मैटर को तय कर चुका है. जब तक कोई नए फैक्ट्स नहीं हैं, हर मामले के अलग अलग फैक्ट्स हो सकते हैं, जब तक कोई नए फैक्ट्स नहीं है या सुप्रीम कोर्ट उसको रिविजिट करने के लिए तैयार ना हो जाए, ऑनरेबल सुप्रीम कोर्ट के ऊपर ही है कि वो रिविजिट करेंगे या नहीं करेंगे। तो
सर मेरा पॉइंट एक था कि पार्लियामेंट में खड़े होकर के मिनिस्टर ऑफ कंज्यूमर अफेयर्स ने स्टेटमेंट क्लियर कट दी है कि हमने हेल्थ केयर को ड्राफ्ट बिल में इंक्लूड किया था और पार्लियामेंट के बहुत से मेंबर्स ने हमें अप्रोच किया है कि हेल्थ केयर को कंज्यूमर प्रोटेक्शन एक्ट से बाहर किया जाए। ये सारी चीजें ट्रांसक्रिप्ट्स अवेलेबल हैं, ये वीडियोस स्टेटमेंट देते हुए। अब प्रॉब्लम इज रामविलास पासवान जी इज नो मोर। कल को अगर हम इस मैटर को लेके भी जाएं तो हम कोई ब्रीच ऑफ प्रिविलेज के लिए उनको हम पार्लियामेंट में झूठ बोलने के लिए हम अब कुछ नहीं कर सकते। बट द पॉइंट रिमेन्स कि was the nation misguided deliberately and this loophole left because there were clear statements which are recorded, there were newspaper articles। हम अगर राज्यसभा की वेबसाइट पे जाएं या अगर हम लोकसभा के उस पे देखें तो ट्रांसक्रिप्ट हमारे पास अवेलेबल है, जिसमें गवर्नमेंट ने क्लियर कट अश्योर किया है मेंबर पार्लियामेंट्स को कि हम हेल्थ केयर को कंज्यूमर प्रोटेक्शन एक्ट में नहीं इंक्लूड करेंगे। एंड देन दिस बिल वाज पास्ड।
सर वो एक मैटर प्रिविलेज का हो सकता है, ऑनरेबल मिनिस्टर आज नहीं है, उनके विरुद्ध एक प्रिविलेज का मोशन हो सकता था, परंतु जब बिल लोकसभा में पासिंग की 3 स्टेज होती है, थर्ड जो स्टेज होती है जिसमें क्लॉज बाय क्लॉज बोला जाता है और पासिंग होती है, उस पर वॉइस वोट होता है, जो जब थर्ड रीडिंग में बिल की थर्ड रीडिंग में जब बिल पास हो गया सर, जो पास हुआ वही उसी पे राष्ट्रपति ने सिग्नेचर किए और वही माना जाएगा सर। लीगल क्वेश्चन तो यही है। ये बात बिल्कुल सही है, मैंने भी पेपर में देखा था, ऑनरेबल मिनिस्टर ने बात कही थी। बात ये थी, हम भी होपफुल थे कि इसको हटा रहे होंगे, परंतु वो हटा नहीं, एक्सक्लूड नहीं हुआ हेल्थ केयर।
Unless specifically excluded or
unless specifically बिल्कुल यही क्वेश्चन है, लीगल क्वेश्चन यही है।
Yes, Sethi, you want to ask something?
There's a lot of discussion about Indian scenario. मैं डॉक्टर गोविंद सेठी से पूछना चाहता हूँ, क्या उनके वहाँ भी मॉब वायलेंस वगैरह कभी होती है?
I have not experienced it, to be honest. But what happens is, definitely, accident emergency, the problem is not the violence. The problem is alcohol. The patient on Friday and Saturday, they do come, you know. The thing is, they get drunk, they get fall, but you can't disregard their alcohol as the cause of fall. Maybe they have a head injury. So the ambulance will come and bring the patient. Sometimes they are rude, and sometimes they may even speak ill about you and might even say F words. Unfortunately, the doctor cannot say anything. There is a protection, there is a police you can call, or the guards in the hospital, but I've never seen any patient who is at a fight or a tussle with the doctor. I've never faced it. I had one patient who, while he was there talking to me, he raised his voice, and we tried to pacify, and maybe they've got right to complain. They do complain, because whenever I see the patient, they go and see to get next appointment. What will happen is they will say, well, I'm not happy. So they will say, okay, you have got a right to file the complaint. They may say, okay, the doctor didn't give enough time. I wasn't happy with the answer. But violence I've not seen, because I don't work in casualty. Patient who work in casualty, they do have a concern, but I don't think the way it is in India, definitely not. They might not speak good to the doctor. They may use, or they may speak ill. They may use F word. They may abuse, but the doctor cannot do anything. If the doctor raises his hand, he had it. So yes, anybody who raises a hand had it. But culture-wise, it's not tolerated. If you abuse the doctor, he will be taken to task, and the people will come, and the police might ask him to leave the premises. But I've never seen, but I do hear from India, it is unfortunate. I feel you people have got a very hard work and hard job to face patients individually, because you've done your best. But what they don't realize is, that, death is inevitable. you will die as part of the treatment. Here, patients are aware of it. Most of my consent, if I do a joint replacement or a hip replacement, my consent is always there in form of death is there. And they need to sign it. If they don't sign it, I'm not operating. But if I was in India, would I do it? I don't know. I would have probably, because I never used to. I might be losing patient. If I tell my patient there is a 1% chance of dying, yeah, or anything like that, that will go against me. So we are privileged. We don't worry about it. We just do our job and let the NHS take the care of it. Unfortunately, in your system, it is difficult. It's very difficult. And I've worked for 5 years in India, and I can see the difference. I was always used to be scared sometime if anything has happened wrong, not because of anything, but the patient may be abusive to you. Things have got worse since I left, actually. It wasn't that bad when I was there, but now doctors are manhandled, which is not great. It's sorry to know that. But I feel sorry about you people that you have to go through this such a hard time, doing your very best. But there, I think maybe education is there. Patient don't pay anything here. It's free of cost. So they can't have any grudge about it. And they know about it. We always tell them there is a chance you may die. Okay, doctor, we know that. So he signs or she signs to it. But here we stand,
In India, we are proud to be spending the 4th lowest across the world. We are ranked 4th lowest in healthcare spending. So obviously, free treatment for Indians is a dream which is not going to be fulfilled soon. And because of that, probably we'll continue to bear the brunt.
And you don't know whether how free is going to be NHS. Maybe when I need my joint replacement, I might have to shed some money, but it will not become totally free. I have a feeling, like for example, dentistry used to be free, but now if I have to go to the dentist, I need to pay some money. And I'm expecting that freebies are not going to be there. It is becoming so expensive. I've seen when the lady used to come, the food was free, still free, but things are changing. The money is running out very quick. And I have a strong feeling if you are in a reasonable salary, you will have to pay some money for a joint replacement, which is free now. Maybe when I need it, they might say, okay, give £1,000 because the cost of joint replacement in the hospital is around £8,000. So for people who don't have much income, they might be free. We might have to pay. But the money is drying, the money is running out. So yes, it may not be free, but I think the concept of people education-wise, and they have no choice also. Also, they don't, if they have a fracture or anything, they will come to the next hospital. They don't come for a doctor. They come for a hospital. So it's a different, and also, what about mob? There is mob. They don't have any friends or relatives to come to see you, to be honest. I mean, that's the biggest thing. If you get operated, if my father was here, if my father's getting operated, I will no way leave my job and be within next to it. No way. I will not I won't get a leave to go. They said he's being operated. We will inform you he's doing well. Come at the time when we allow you to come. So there is no way you can gather more. Unfortunately, that's probably the best part of it. And the family values are different. You only attach to very close. No friend is going to be shouting at him, And if you make a violence, the biggest thing is if you create a crime, you go onto the register. And when you go on a register and next time you apply a job, you aren't going to get it. If I used to go from one hospital to another, every hospital, I used to have my CRB checked. If I work in a pediatric department, I'll be checked whether I had a history of pedophile or not. So once you are branded a problem, you had it. You are on the system and your next job is a problem.
So there they don't have people to have a mob collected to fight for them. That's good.
I've never seen it. They may protest by, on the paper, but I don't think you will be.
There are many people waiting to go to create ruckus. That's good. So anything else?
Great presentation on telemedicine by Dr. Verma. Just one question. Telemedicine was a no-no earlier. Now, due to COVID pandemic, teleconsultation has been made legal. But there are a lot of pitfalls of telemedicine. Should we ideally continue telemedicine even after the COVID is over? Because once the patient becomes sick, then retrospectively everybody is very wise in history. So then you may be asked that why did you do teleconsultation when the patient was getting serious? So when the pandemic is over, should telemedicine be continued in the Indian context?
Asking from me?
Yes.
Should I answer, sir? Well, these telemedicine guidelines have been issued by the BOG, the Board of Governors, and it has been notified and has been gazetted. That means it is going to stay here in any case. It was not legalized before that, but now the importance of telemedicine has been realized by the government. And there are limitations of the telemedicine we should understand. And especially during these times when the doctors are concerned about their own safety and safety of the patients also, then if something has been done beyond limits also, I don't think that will be treated as a negligence. But once the epidemic is over, then we should realize what should be the reality, and we should what are the constraints and boundaries of the telemedicine. But in any way, this is very beneficial for the patients who are placed at the distant places, who don't have any medical services as such, and it is, in my opinion, it's rather a boon for them. But we should not do any malpractice in the sense that if the patient does not require telemedicine as such, he should be referred for an in-person. I also think that way, that once the pandemic is over, then there may be some constraints and there may be some strict guidelines regarding telemedicine. Government may be a bit soft at the moment. That's my view.
Dr. Ashwani, you wanted to ask something?
No, I didn't want to ask anything. It is okay. It's a comment, come advice, wanting to seek an advice and possibly a question. And the same in telemedicine. See, I would normally print a disclaimer that on telemedicine, only a limited opinion is possible. The patient is strongly advised to come for a physical examination at the earliest available opportunity. That is a standard print that I sent.
It is already there, sir. It is already there.
No. So it is. I'm not changing the law. What I'm saying is that it is there in my prescription.
Yeah. We should do like this, sir.
This is my prescription.
I should tell you one thing, that before these guidelines, there was Telemedicine Society of India, and I went through that lectures and all that. So there are very good lectures which are present over the social media, and they have explained this thing in great detail. I didn't have much time to listen to those topics, but I will definitely listen to these once this webinar is over because those lectures are very good, and they have explained everything in great detail, even when these were not legal. These were not completely legal.
See, the question which I wanted to ask,
they have suggested how the informed consent should be taken. What you have just said, that whenever a doctor comes in contact with a person on phone, he should have a set language that I am such and such doctor. I can give you this advice, and I will be giving advice to the best of my knowledge and in the best of your interest. Then you should start. And when the patient says yes, that means that is the informed consent he is giving. So this time, yes.
So the other pitfall which I wanted to really talk about and ask every panelist here is that probably the application of mind has not been there when they've drafted the lists of the medication which you can provide. See, they are trying to control what you can prescribe. As a gastroenterologist, there are patients who I find the symptoms of gastroenterology have in their origin a mental sickness. And I know that I can address that and treat that. Now, if I'm not able to prescribe a Schedule X drug, the patient may go violent at that time. Then the patient would come, somebody would come and ask me, why did you not do it? Number one. Number two, the reason given for that a list, Schedule X list cannot be prescribed is that it is likely to be misused. Tell me, is it not being misused now? What more misuse can be done? Or in what other way can misuse be done? Today, if you go to any chemist and just even tell him on telephone, he'll send the medication at home. So I do not know how is it likely to be misused because if it is a potential of dependence in that.
I agree with you, 100% on this aspect, because if it is going to be misused by telemedicine, so that will have a proof that it has been misused. I fully agree with you on this point.
Can I come one way? I think we have a similar system before COVID also, just to take the pressure away from the GPs, you know. There are nurses who will ring certain number and you could be contacted to them. But there are two medicine. One are prescription drugs, one are non-prescription drugs. If a patient has got a tummy ache or something like that, you know, there'll be certain medicine only he can go and buy. Other medication he just cannot buy. So these are non-prescription drugs, like you can ibuprofen, you can get it. You can get paracetamol, but you can't get any antibiotics for sure. So there we have a telemedicine for going for a long time, but this is a smaller country and you know, that is probably can easily be governed. But place like your, but there's no way they would be prescribing any medication which are antibiotics or something which are non-prescription prescription drugs. So non-prescription drugs can be dealt, but that is at a level basic problems, you know, not something a cardiac event or something like that. And as I was talking about the red flag sign, every time you go.
See, the point is not that, Dr. Sethi, the point is not that. The point I'm trying to make is that how is it different when I prescribe a medication after seeing the patient, and how is it different when I'm seeing the patient prescribing the drug on telemedicine? The same prescription is presented. It is in my disclaimer, it is there, it is valid only till the time I've made it so, right? And the same prescription is presented n number of times to the chemist and he honors that. So whether it is a telemedicine generated prescription or whether it is my handwritten prescription after examining the patient, the potential for a misuse remains the same. I'm not saying it is less or more.
Sir, I think the improvement will come in stages. Now they have allowed some psychiatric drugs. 3 psychiatric drugs. These
again, this is again they are trying to control. A psychiatrist would need to prescribe say 100 drugs or 10 drugs or 20 drugs. Why only these 3? And most of the psychiatrists after the COVID have not come to the hospital because they say it is only a verbal interaction. They don't need to examine the patient.
So maybe they are thinking of treatment of patients with minor ailments as far as this COVID period is concerned.
Sir, it has to be all pervasive. You cannot make a selective law or give selective conditions.
What we have got is repeat prescriptions. For example, a patient with diabetes or psychiatric drugs, you know, what happens, he is allowed to get a repeat prescription, but then it has to be in a certain, you can't get more than certain amount of medicine. So every repeat prescription, but the only thing is they will have a record that this patient had a medication for 15 days. He gets 15 days and he can't get another one before another 15 days. But that's controlled. But again, you know, it's a small place you can work. It's difficult. And there, the chemist also.
Not only that, the pharmacy is governed by laws which are implemented, which are enforced.
Exactly. That's the way. Because the pharmacy will not let you have a medicine more than. I remember, you know, it's a funny way to say. My mother-in-law, she feels that ibuprofen from here works better, which is, I think, absolutely wrong. She feels anyway. The brufen over here is better than the brufen in India. And anyway, when I went to ask, because it's coming for, I said, okay, let me get 8 packs of ibuprofen. They all carry 12 tablets in a small pack. On the counter, I was told you can't have more than 3. I had only got 3 then. If you take paracetamol, because the paracetamol toxicity, it is a difference. I can go out and ask my wife to get another one. Or I may go again after a second time to get, that's different. So there is a bit of control. But you're absolutely right. The pharmacy is so well regulated. Any medicine what they give out of the counter is known to the people and known to the system.
Right.
Chalo, Dr. Suroi, very
my internet connection was very unstable, so I could not thank. I thank all of you for the
unsaid thanks kabul kare sir.
My internet connection is not good, sir.
सर हम मान गए ना आपने क्या कहा. बहुत बहुत धन्यवाद.
जी, thank you, sir. Thank you. Thank you, everyone. But now I think I am audible now.
Yeah, you are audible. You are audible.
Not
I
visible.
thank all of you, sir, for such a nice discussion and such nice topics, and hope that we will meet in the future also, sir. I hope the audience must have
कोई आर्काइव बनाओगे, इसकी कोई रिकॉर्डिंग बनाओगे?
It will be there on YouTube.